Okay, folks, welcome to the last topic for this course. We're going to be covering gastroenterology. We're going to do that in one PowerPoint narrated video. That duration is probably going to be somewhere around 2 hours and 45 minutes. It'll definitely be under 3. To start us off, here you can see some of the select readings and figures that I pulled out of chapter 41. In our textbook, these are all worth taking a look at as you study for this unit. The GI tract is one long tube from mouth to anus, and along that tube, we're going to encounter a number of other solid organs, such as salivary glands, liver, and pancreas. The GI tract is all about ingesting food and then digesting the food, both mechanically and chemically, absorbing the nutrients. All along the GI tract, we are putting products into the lumen. That's referred to as secretion. And then eventually, those ingested products which are not absorbed are going to come out. So we have to talk about elimination as well. That tube of the GI tract is made up of 4 distinct layers. So going from outer to inner, we have the mucosa, then the submucosa, the muscularis externa, and the serosa. And as you'll see, each layer varies depending on what section of the GI tube you're in, and each layer is susceptible to a number of different pathologies. We'll look at each of these in depth as we move down from north to south. Here you can see histologic views of 4 areas of the GI tract. So starting in the upper left, we have the esophagus, then the stomach, and then lower left, we've got the small intestine, and then the large intestine. And you can see that they vary fairly significantly in terms of how they look. So not only in terms of how they look, but in terms of what's going on in the physiology of each. And as we move through this unit, we'll talk about each of these specific layers as it pertains to each of the different organs. The mucosal layer is the inner lining of the GI lumen. So going from top down, we're going esophagus, stomach, small intestine, colon, and you can see the variation in terms of the gross anatomy. What does it look like if you were staring at it with an endoscope? And then in terms of the histology, what would it look like normally if we did a biopsy? The mucosal layer is made up of epithelium, a small amount of muscle called the lamina muscularis, and a little bit of connective tissue called the lamina propria. The primary function of the mucosal layer is to absorb, but it's also to secrete. So a number of products, including water, are secreted into the GI tract to aid in the digestive process. The mucosa is an area where there are numbers of different types of transporters and ions able to move water-soluble, large polar molecules in and out of the GI lumen. That mucosal layer is the target for numbers of drugs, and we'll be looking at that as we move through. Those cells are rapidly dividing. We are constantly turning over the epithelial cells of the mucosa in the same way that we're turning over the epithelial cells of the outer skin. It is those epithelial cells of the GI tract which are most prone to cancer, and we'll be looking at a number of different cancers of the GI tract as we move on. The submucosal layer provides the blood supply for the mucosa. So remember, epithelial cells do not have their own vasculature. They're dependent on oxygen and nutrient diffusion. That's coming out of the blood vessels of the submucosal layer. In the submucosal layer is a small amount of neurons referred to as Meissner's plexus. Those neurons are what's innervating that small amount of smooth muscle in the mucosa. Some layers of the submucosa have mucus glands, and those mucus glands are going to secrete watery mucus into the lumen, which will be helpful in propelling moving food from north to south. And like the other areas of the GI tract, the submucosa will be variable depending on which area you're in. If you look at the bottom left picture, I've highlighted for you what some of those neurons or Meissner's ganglion cells look like in a tissue biopsy. The muscularis layer is all about moving things, peristalsis. So when smooth muscle of the GI tract contracts and moves food, we refer to that as peristalsis. Peristalsis kind of occurs in waves, and again, it's due to contraction of smooth muscle. The type, or I should say the distribution of that smooth muscle is a little bit different as you move from all the organs. The stomach and the colon have a large amount of smooth muscle wrapping around it. There tends to be an inner circular layer and then an outer longitudinal layer, and then just kind of picture those layers contracting in waves, forcing the contents of the GI tract from north to south. All muscle needs neurons, electrical impulses, for them to contract. So the name of those neurons in the muscularis layer is referred to as Auerbach's plexus. And those are part of the parasympathetic nervous system. Remember, the parasympathetic nervous system is rest and digest. So those parasympathetic neurons are important in the digestive process, and to have the digestive process occur, we need peristalsis. The primary neurotransmitters of the GI tract, which affect smooth muscle contraction, are both serotonin and acetylcholine, and we'll look at why those are important and how GI tract peristalsis can be manipulated by using drugs that act at those two neurotransmitters. So the parasympathetic nervous system, remember, rest and digest, comes from two areas. It comes from the 10th cranial nerve, the vagus nerve, and it comes from the lowest end of the spinal cord, S2, 3, 4. And the parasympathetic nervous system of the GI tract promotes peristalsis, it promotes secretion, it promotes the release of digestive enzymes and hormones, and it's important in opening the rectal sphincters and allowing the process of defecation. The parasympathetic nervous system utilizes the neurotransmitter acetylcholine. So if we block acetylcholine, we refer to that as being anticholinergic. So what do you think are the effects on the GI tract of an anticholinergic drug, or a drug which is blocking acetylcholine? I'll give you a second. Did you answer? Your answer should be the GI tract gets dry and the GI tract loses peristaltic activity, which could lead to bloating, ileus, and constipation. Let's talk about some exocrine glands. And let's start by talking about the exocrine glands of the oral cavity, so the salivary glands. So we produce about 1 to 1.5 liters of saliva per day, which gets secreted into the mouth. Hopefully most of that you're swallowing and not spitting out onto the street. The role of saliva is for lubrication of the food bolus, so we definitely get mucus and saliva. We have some digestive enzyme in saliva, primarily amylase, which is used in the beginning of carbohydrate digestion. We have lipase, which is used in the digestion of fat. Saliva contains some IgA antibody to protect us against pathogens which are swallowing. And it contains another enzyme called lysozyme. If you remember in our skin lecture, we talked about skin having lysozyme and that enzyme being important in degrading bacterial cell walls. So we have some of that enzyme present in saliva as well. And again, it's the innervation of the parasympathetic gland that leads to these high amount of watery, mucousy saliva. And you can see a cartoon and a histologic biopsy of what a salivary gland would look like. You have the central duct lined by all these epithelial cells which are functioning as glands, and each of these cells are secreting products into each of these cells are secreting products into the duct, and that duct then is emptying into the oral cavity. We have three sets of salivary glands. The parotid gland kind of in front of each ear and just a little, so if you took your ear and went straight into your face and then came down a little bit, that'd be the location of your parotid gland. Sublingual glands under your tongue, submandibular glands under the angle of your jaw. They are going to contain both serous and mucus cells. A cinar refers to an epithelial cell which is secreting. So look at the upper picture and you can see a duct of a salivary gland, and you can see all those epithelial cells lining the duct. Those would be the acinar cells. They're secreting the watery mucus as well as the gamma globulin enzymes that we talked about in the last slide. Myoepithelial cells are smooth muscle cells which can contract, and the contraction of those smooth muscle cells is what allows the propulsion of the saliva into the ducts and then eventually into the oral cavity. And again, getting something from the cells into the oral cavity requires an exocrine duct. So again, what would be the adverse effect of an anticholinergic medication? Inhibiting acetylcholine, inhibiting the parasympathetic nervous system would cause the individual to have a very dry mouth. And I'm sure a lot of you have experienced patients with that adverse effect. Have you ever seen somebody gleek, G-L-E-E-K, you know what that is, gleeking? Those are the individuals that could squeeze and contract their salivary glands and get saliva to kind of like spray out of their mouth in an arc. Look that up on YouTube, gleeking. It's disgusting, but some people are able to do it. Okay, these glands can get infected. So salivary glands and parotid glands can get infected. Patient usually presents with facial redness, swelling, and pain. Some of these are viral, such as children who get the infection mumps, and sometimes these are bacterial. The bacterial infections tend to be a little bit more common in adults. Streptococcus is a common organism causing parotitis or bacterial parotid gland infection. If you're looking at an individual with facial redness, swelling, and pain, to determine if it is the salivary gland, you really want to be able to do a bimanual palpation. So one finger inside the mouth, one finger on the outer portion, and you should be able to feel an enlarged, tender gland. Sometimes obtaining a serum amylase level is helpful in making a diagnosis, because again, those glands make amylase, and when they get edematous, inflamed, and permeable, they will leak amylase. So you might be able to pick that up in a blood testing. And then the other thing that I want to say is when you're doing that bimanual palpation, try to visualize the duct. The parotid duct and the sublingual ducts are probably the easiest ones to see. So do this to a willing volunteer. Look in their mouth and see if you can find that parotid duct. It's highlighted in the upper picture at the black arrow. And then have them lift up their tongue, and you should be able to see fairly easily the ducts of the sublingual glands. And on an ultrasound, you can usually see the increased distension, edema, and fluid collection in the glands, as well as the increased vascular perfusion of an infected gland. So the ultrasound pictures at the top show you a normal parotid gland at the left, and then in the center and on the right, you can see that collection of fluid within the duct, probably likely to be an abscess in there, and you can see the increased vascularization. The CT scan in the lower left shows you a big abscess of the parotid gland at the white arrow. And then the last two pictures, both on the CT scan and looking directly under the mouth at the duct, you can see a stone. So that is not too uncommon in adults, is to get concretions of the mucus which crystallize and then form stones within the gland itself or within the duct. And blocking that duct, like blocking any other duct, can lead to distension of the gland and a risk for secondary bacterial infection. The CT scan shows it really nice. At the blue arrow, you can see the calcified stone, and then at the red arrow, you can see the dilated duct. All right, a couple other oral pathologies, canker sores versus cold sores. Canker sores are inflammatory and non-infectious. They typically come on as a single painful lesion on the inner mucosa only. Best treatment for that is something such as a topical local anesthetic, such as Oragel, or use of something like Tylenol or ibuprofen. Again, these are inflammatory. There could be a number of different causes for this. Some people break out in a lesion like this due to stress. Sometimes it's due to citrus or other types of foods. Again, those are painful but non-contagious. Versus a cold sore, which is a herpes simplex infection, those tend to be multiple lesions, multiple painful lesions, as well as lesions on the outer mucosa. So if you see somebody with those type of lesions, right, don't kiss them, because that's going to give you exposure to HSV. HSV is highly contagious, and as you know, it could reoccur, it could be dormant. So we learned about the dorsal root ganglion in the neuro unit, so that herpes virus is able to stay for a long period in that dorsal root ganglion and reactivate. Management of this would not only be pain control, but also antiviral drugs such as acyclovir or valacyclovir. There is an antiviral drug out on the market now, which is topical, called Abreva. Abreva is antiviral. It's not a local anesthetic. It's actually a really long alcohol which can get into the capsule of the virus and prevent viral replication. So don't mix those drugs up. Oragel is a topical local anesthetic used for controlling pain. Abreva is a topical antiviral, which is only going to be effective for cold sores or HSV infections. And then oral cancers. Cancers of the oral pharynx primarily come from the outer squamous epithelial cells. So remember, carcinoma is a term that we use for cancer of epithelial cells, because the predominant type of epithelial cells in the oral pharynx is a squamous cell. These cancers are referred to as squamous cell carcinomas. They tend to be painless. They tend to be very irregular with raised edges. They can become highly invasive. Most of the time, they will initially begin in the lower region of the mouth and under the tongue. And these are lesions that once they're there, they don't heal. Unlike a canker sore and cold sores, which are painful, relatively small in size, those typically go away in 5 to 10 days. These squamous cell carcinomas are persistent. They continue to grow, they don't heal, and they tend to be painless. Risk factors for squamous cell carcinoma includes the use of any type of tobacco, including chewing tobaccos, cigars, cigarettes, pipes, etc. Alcohol, something we don't see a lot in the US, but chewing of a nut called a betel nut or a betel nut. Popular in Asia, they tend to have a high concentration of nicotine-like substances in it. So it's like, we like chewing tobacco here in the US, betel nuts in Southeast Asia. Exposure to human papillomavirus, oral radiation, and you can see that the male to female risk is about 3 times greater in male. A lot of baseball players used to do a lot of tobacco chewing. Major League Baseball got all over that and really trying to get young kids and high school athletes and college athletes to stop chewing tobacco. So that's why you see a lot of sunflower seeds and bubble gum being used in Major League Baseball. They've really taken a nice stance of trying to get young males to stop using smokeless tobacco products, chewing. So if you know anyone who's chewing tobacco, it's kind of gross, but help them stop, because that is one of the biggest risk factors for these types of cancers. I'm sure a lot of you have seen these. Look up squamous cell carcinoma in some Google images, and you can see just how invasive and just how nasty some of these types of cancers can get. We're going to keep moving down the GI tract, going north to south, and now let's talk about swallowing. Swallowing is a complex process of voluntary contraction of smooth muscle, voluntary contraction of skeletal muscle, not smooth muscle, skeletal muscle, and those pharyngeal constrictor muscles and all the different muscles which are used for chewing and swallowing. Because they're in the head and neck, they're innervated by cranial nerves. So cranial nerve 9 and cranial nerve 10 play a huge role in the innervation of those muscles which are part of the pharyngeal plexus or the pharyngeal constrictors. Remember, when we swallow, the tongue has to push the food bolus back, and the epiglottis must be able to block the trachea so that the food bolus and liquids that we're swallowing don't end up into the larynx and down the trachea. So let's see, look at that lower cadaver picture, and can you identify everything at the white arrow? So going from top to bottom, we've got the posterior pharynx. You can see the flap of epiglottis immediately below that. You can see the base of the tongue right in front of the epiglottis, and see that region there between the tongue and the epiglottis, the vallecula. That's typically where the blade is placed during an intubation to pull the epiglottis out of the way to open up the trachea. Then you can see the trachea right underneath the epiglottis, or I should say the larynx, moving into the trachea. And then posterior behind the larynx is the esophagus. That's the 4th arrow. If you've never seen a video swallow study, look on Blackboard. I'm going to post a couple of videos for you showing you a normal fluoroscopy, and then showing you a highly abnormal fluoroscopy where the individual is aspirating. And now think for a couple minutes what types of patients are at risk of aspiration. And if this is a coordinated process which requires skeletal muscle contraction, and all skeletal muscle requires neuroinnervation, if a person has had a stroke of the central neurons innervating those skeletal muscles, those individuals are going to be at high risk of aspirating. So let's stick here and talk a little bit about the esophagus. The esophagus is the long tube which begins at the posterior oropharynx, comes through the chest, through the diaphragm into the abdominal cavity, and then connects with the stomach. The junction of the esophagus with the stomach is what's referred to as the lower esophageal sphincter, and the lower esophageal sphincter is found in the abdominal cavity below the diaphragm. The lower esophageal sphincter is not part of the diaphragm, it's actually below it. That lower esophageal sphincter is typically pinched closed to prevent retrograde regurgitation of stomach acid and food back up the esophagus, and during the swallowing process, that lower esophageal sphincter has to relax and open up to allow food and liquids to pass from the esophagus down into the stomach. So the first third of the esophagus is skeletal muscle. We can voluntarily contract that. The bottom 2/3 is smooth muscle, and that contraction is from the autonomic nervous system. When we start to voluntarily swallow and contract the proximal esophagus, the distal esophagus by reflex will contract and further move that food down into the stomach upon relaxation of the lower esophageal sphincter. We really do not do a lot of absorption out of the esophagus. The esophagus is primarily a secretory organ, secreting mucus into the lumen to help propel the food bolus down easier into the stomach. On the cadaver section, you can see that the esophagus has been left intact on this dissection, and you can see that long hollow tube coming through the diaphragm, and then you can see its junction with the stomach, and that junction is the lower esophageal sphincter. So two pathologies, dysphagia, difficulty swallowing, and odonophagia, pain swallowing, and you can see there are a number of different pathologies that can lead to an individual having difficulty getting the food bolus down and having pain getting the food bolus down. One very common acute cause of this would be impaction in the esophagus, whether that's from food or non-food foreign body. Individuals who have esophageal strictures, which may be congenital or after trauma, radiation, severe reflux disease, which we will cover, inflammation of the esophagus, cancer of the esophagus, those two we'll look at really quickly. Radiation and fibrosis, so individuals who've had radiation for certain types of breast or lung cancers, long-term complication of that radiation to the thorax can lead to esophageal fibrosis. There are some autoimmune disorders that can lead to inflammation of the esophagus. There is a motility disorder referred to as achalasia that a number of individuals suffer from. This is due to ineffective peristalsis of the smooth muscle in the distal 2/3 of the esophagus. And then again, individuals who've had a stroke, particularly if that stroke involved cranial nerves 9 and 10, the innervation for those pharyngeal muscles, those individuals could have marked difficulty with swallowing. So there's a fairly big differential diagnosis for dysphagia and odonophagia. So in terms of working it up, let me give you a couple things that we can suggest here is, number one, first try to localize the pathology as being either oropharyngeal or esophageal. If the individual develops symptoms initially when initiating the swallow, particularly choking, or if they have pain with talking, difficulty talking, dysarthria, pain with talking, dysphonia, probably dealing with the more proximal type of pathology. If the individual has symptoms seconds after swallowing begins and has thoracic or retrosternal complaints, that's probably an individual who has more distal esophageal pathology. So we can look at the acuity and other types of symptoms. Is it sudden onset versus happening a couple seconds after swallowing has initiated? Other things to determine, are they having respiratory symptoms? Are they regurgitating? Is blood coming up in the regurgitation? Are they losing weight? Some diagnostic testing can be done, which can be done, could be a barium swallow, or maybe more importantly, looking directly with an upper endoscopy. And there's some motility testings that can be done. I don't know a whole lot about that, so you'd have to talk to a gastroenterologist in terms of how motility is actually tested in the esophagus to make a diagnosis such as achalasia. Well, now let's see if you can come up with 4 different diagnoses here. So I got a patient with esophageal cancer, person with a foreign body, person with gastroesophageal reflux disease, and an individual with esophageal candida infection, candidiasis. So I got 4 different patients there in the 4 different boxes. Can you determine which of those patients is one of those 4 diagnoses? And as we move on here and talk a little bit more about the esophagus, if you're looking at it now and you can't decide by the time we're done talking about the esophagus here, you should definitely be able to do that, okay? Cancer, foreign body, reflux disease, and candidial infection. All right, let's try this first. Saturday night, about 2:30 in the morning, Bob wakes up with a feeling of regurgitation, nausea, burning chest, and abdominal pain. He had a lot of alcohol earlier in the night and had a spicy meal with that. Sounds like Bob is having symptoms of acid reflux or gastroesophageal reflux disease. This is when stomach acids and gastric backwash refluxes back up into the esophagus. So the stomach is really high in hydrochloric acid, and if the tone of the lower esophageal sphincter is compromised, if that lower esophageal sphincter is not constricted, it could be easy for stomach acid contents to reflux up into the esophagus. And the esophagus mucosa is very sensitive to that. You've probably all experienced episodes of heartburn at one time or another, and you know it can be a cause of fairly significant epigastric and retrosternal pain. Some risk factors for esophageal reflux disease is age. This goes up as incident goes up as we get older. Foods, everyone is different. Some people can and some people cannot tolerate things like citrus and spicy foods. Overeating and distending your stomach, smoking, alcohol. Alcohol actually lowers the tone of the lower esophageal sphincter, making it more likely that you are going to reflux after drinking alcohol. Obesity, diabetes, pregnancy, any type of injury to the stomach or post-stomach surgery, and individuals who actually have a hiatal hernia where part of the stomach is kind of moving upwards and through the diaphragm. We'll look at a picture of that in a minute or two here, right? So persistent refluxing of acid can lead to damage of the esophagus due to the direct damage of the acid and due to the inflammatory response which occurs when the esophagus is damaged by those acids. So another sign, another slide here, reviewing for you GERD, gastric esophageal reflux disease. And you can see in the cartoon, again, when the lower esophageal sphincter is closed, should maintain gastric contents in the stomach, and the contents should then continue to move south through the pyloric valve and into the duodenum. But if the lower esophageal sphincter has been relaxed or there's pathology of the lower esophageal sphincter, you can see the refluxing up of those gastric contents and gastric acids up into the esophagus. Again, reviewing for you some risk factors and reviewing for you symptoms and complications. Managing gastroesophageal reflux disease can be done by reducing gastric acidity. There's a lot of different drugs that can do that. We'll look at in a minute or two here. Other things that can be done in terms of pharmaceuticals is to enhance gastric motility and tighten the lower esophageal sphincter tone. So if you can close the lower esophageal sphincter tone, make it tighter, and make the stomach empty quicker through the pyloric valve and into the duodenum, you will also minimize the risk of gastroesophageal reflux disease. One drug that's on the market that has that mechanism of action is Reglan or metoclopramide. Everything else is reducing gastric acidity. Okay, on the left you've got a hiatal hernia, so a prolapse of the stomach through the diaphragm and up into the thorax. That prolapsed stomach may slide back and forth from thorax to abdomen. That's referred to as a hiatal hernia. Most of those individuals have pretty significant symptoms of GI reflux. And then on the right, we have a phenomenon referred to as Barrett's esophagus. And this is a phenomenon where the epithelial cells in the esophagus are replaced by the epithelial cells of the stomach. The epithelial cells of the esophagus are primarily flat, stacked, squamous epithelium. The epithelial cells of the stomach are glandular epithelium. Long-term gastroesophageal reflux can lead to replacing of the esophageal squamous cells by stomach glandular cells. And when that occurs, it's referred to as Barrett's esophagus. This is a pre-malignant condition for glandular cancer of the esophagus or adenocarcinoma of the esophagus. And here you can see the junction between the epithelial cells of the esophagus on the left and the glandular gastric stomach cells on the right. Again, that's a precancerous lesion known as Barrett's esophagus. That risk is highest in males, particularly white males over the age of 60, and in individuals who have had reflux symptoms ongoing for greater than 10 years. And here's esophageal cancer. So it's a squamous cancer or an adenocarcinoma depending on what part of the esophagus the cancer occurs. In the more proximal area, it tends to be squamous epithelium. In the more distal area, particularly close to the lower esophageal sphincter, tends to be adenocarcinoma due to that change to Barrett's esophagus. Esophageal cancer can present as a polyp. It can be infiltrative, it could be ulcerative, and it can spread via lymphatics. And like all other cancers, it maintains those properties of anaplasia, invasion, and metastasis. So look at the histology. You can see normal esophagus on the right, And then as you move over to the left, you see all this invasion of glandular epithelial tissue going into the squamous epithelium, but also going deeper out of the mucosa and getting into the submucosa and mucosal layer. That would be an example there of an invasive carcinoma. So risk factors, males greater than females by about 4 to 1. African American Black has the highest race ethnicity. Use of tobacco products, alcohol, past HPV infection and exposure, radiation, I don't know why I got HPV in there twice, chronic reflux disease, and definitely if that led to Barrett's esophagus. Classic presentation may be a male who's a smoker, who now has difficulty and pain with swallowing, losing weight, has an episode of aspiration, spits up or throws up blood. That type of individuals with risk factors definitely needs to be looked at in terms of an endoscopy, because that would be a high-risk individual with symptoms worrisome for cancer, particularly with the weight loss and the coughing up or spitting up of blood. Upper photos here are showing you the normal esophageal epithelium, and then the lower two pictures are showing you examples of anaplasia and invasion in esophageal cancer. So look at all the high variability between those cells in the left photo, and look at all that invasion of epithelial cells going on into the deeper structures of the GI lumen in the lower right photo. So some nice examples of esophageal cancer showing you both anaplasia and invasion. All right, how about we talk about this? Babies with reflux. What is baby reflux, and when should we not refer to it as infant colic? So gastroesophageal reflux, just like it occurs in adults, can occur in infant. About 2/3 of babies will experience this while they are under 4 months of age. By about the time they get to 1 year of age, less than 10% of kids have this. So they tend to outgrow it. And some of that has to do with the anatomy, as the lower esophageal sphincter picks up more tone, the incidence of GE reflux tends to decrease. And the more time that the baby spends upright as well, the less incidence of gastroesophageal reflux. So you as an adult get reflux, you get this burning sensation in your chest and throat, and because babies don't talk, when they sort of don't say, "Excuse me, mom, but I have this retrosternal burning," right? What do? They cry and scream. So a crying, screaming baby who's crying and screaming consistently, sometimes is referred to as being colicky. So while a lot of infants have gastroesophageal reflux and get irritable, we don't want to call the infant colicky if there is more significant threatening pathology going on. So very important in irritable infants, before we just pass this off as being GE reflux, that a relatively good history physical exam and diagnostic modalities are done to determine whether or not this infant is truly suffering from symptoms of GE reflux versus something more threatening. This is not colic. So irritable infants who are septic, have infections like a urinary tract infection, have a hernia, have been abused, injured, are not being fed, have severe eczema or allergies and they're going crazy because of the itching, bowel obstruction, CNS pathology, right? Ear infections. So in the photos here, we've got a broken clavicle, which may happen as a result of abuse, otitis media, fairly common cause of irritability in young infants, hair tourniquet syndrome, hair or some other strand of fiber gets wrapped around a digit. You'd be surprised how often we see that. Incarcerated hernia on the lower right. Again, all these types of things are not colic. If you got an irritable baby, they got to be looked at head to toe to determine whether or not there's some real pathology there. We can't just attribute GI tract dysfunction, GERD, to all infants who are irritable. But for those babies who get it, symptoms that you can see would be the wet burps, right? You burp the baby and some of the formula comes back up. Babies who are crying, babies who have feeding intolerance, babies who aren't sleeping well because as they're put on their, as they're laid down, the incidence of reflux increases. So be careful. Irritable babies, a lot of things to think about before we attribute it to GE reflux disease. Again, most babies are going to outgrow it. Usually simple maneuvers such as keeping them upright for a longer time after feeding, frequent burping, not distending their stomach, so having them drink a little bit, stop them, burp them. Sometimes formula changes are required. Usually simple things like that can get a refluxing baby, make them happy again, right? So when is reflux considered to be severe? If it impacts normal feeding, persistent irritability, if the baby spits up, coughs up blood, has bad weight gain, or if they are starting to choke and cough, and definitely if they're showing some symptoms of wheezing or asthma. So again, just mention the simple interventions, slow feeds, small amounts, frequent burping, lots of laundry, right, from all the wet burps that you're gonna have on your shoulder. Upright post-feeding, car seats are not a good idea because when a baby's in the car seat, that actually increases pressure on their stomach, making it more likely for them to reflux. Some of these incline things, such as the one that you see on the upper right here, much more better than a car seat. Breast milk is usually better than the formulas. Sometimes soy protein formulas are better tolerated than the casein protein formulas. You can thicken the formula by adding in some rice cereal. So if you put a tablespoon of rice cereal into 4 ounces of fluid, mix that up well, make a larger hole in the nipple of the bottle so it can come through easier. Sometimes thickening the formula works better. And then maybe the most commonly used drug in infants is ranitidine. Ranitidine as a gastric acid, as a medication which is going to decrease the amount of gastric acid. It's referred to as a H2 blocker, and we'll look at that mechanism in a minute or two here. All right, moving on. Now we're going to the stomach. So we can see the stomach in the cadaver section. So at the top, we've got the lower esophageal sphincter. And at the bottom, or at the outlet, we've got the pyloric sphincter, which is the opening between the stomach and the C-loop of the duodenum. The pyloric sphincter needs to open and relax to move food out of the stomach and into the duodenum. Stomach is shown at the white arrow on the CT scan at the upper right. You can see a upper GI barium swallow outlining for you the distal esophagus, the lower esophageal sphincter, the stomach, and then the C-loop of the duodenum. On the KUB x-ray, we can see the stomach bubble. See that coin stuck right there? at the lower esophageal sphincter on that x-ray. And then on the ultrasound at the yellow area looking at the stomach, and then the orange line and the green line showing you the thickness and the length of the pyloric sphincter on ultrasound. And the upper solid structure above all that is the liver. So a lot of different ways that we can visualize the stomach with respect to medical imaging. The stomach mucosa has pits, and those pits are lined by gastric glands. We'll look at those in a second. And the stomach has 3 layers of smooth muscle. Again, think about how much you can eat and drink and how much you can distend your stomach. You don't want your stomach to burst. Same thing if if you're poorly bag mask ventilating an individual and you're getting a lot of your positive pressure ventilation going into the stomach, you know that you can distend the stomach to a pretty significant amount. So that compliance and that ability to distend is all due to the smooth muscle. And then as that smooth muscle contracts, it's essentially going to roll the food around in the stomach, and now that smooth muscle will aid in the mechanical digestion of food. If you look in the left photo, you can see those gastric pits, right? Those areas that are diving down into the mucosa, and those pits are all lined by epithelial glands, and we'll look at the importance of those epithelial glands in a second here. So here's a gastric pit lined by different types of epithelial cells. We have mucus cells secreting mucus. That mucus protects the lining of the stomach from acid. We have the parietal cells secreting hydrochloric acid. We have chief cells secreting the protein digestion enzyme pepsinogen, and another protein referred to as intrinsic factor. We need intrinsic factor to absorb what necessary vitamin? Vitamin B12, right? So without intrinsic factor, we can't absorb vitamin B12. The combination of intrinsic factor and vitamin B12 allows that B12 then to be absorbed in the small intestine. And then we have G cells, and those G cells secrete a hormone called gastrin, and gastrin hormone is important as a stimulus to release stomach acid and as a stimulus to begin stomach peristalsis. We have an abundance of hydrochloric acid in the gastric lumen. The pH of the gastric lumen is extremely acidic. Usually a pH is less than 1. What is the role of hydrochloric acid? So hydrochloric acid will activate some digestive enzymes such as the lingual lipase coming from the salivary glands and the pepsinogen coming from the stomach itself. That stomach acid will destroy pathogens. Whether you like it or not, when we eat, we're swallowing a number of bacteria. And that stomach acid is important in the breaking up of the cell wall and connective tissue of plants that we eat and of animal products which we eat as well. So hydrochloric acid, very important in the digestive process and also important in keeping us safe against bacterial pathogens which we ingest. Okay, so what regulates stomach acid secretion? In the parietal cells of the stomach is a protein referred to as the hydrogen potassium ATPase enzyme. It's also known as the proton pump. That enzyme pumps hydrogen ions into the stomach lumen. So that is the source of the acid. That pump can be activated or inactivated by different factors. So the hormone gastrin, the neurotransmitters histamine and acetylcholine all enhance the activity of that proton pump, putting more acid into the stomach. And a hormone referred to as somatostatin is inhibitory. If we wanted to decrease stomach acid secretion, we can use a drug that blocked acetylcholine, that blocked histamine, or that blocked gastrin. And the most commonly used drugs are the histamine blockers or the H2 blockers, such as ranitidine, famotidine, Zantac, and Pepcid. We can also use drugs that directly antagonize the proton pump inhibitor drugs such as omeprazole, pantoprazole, lansoprazole. Okay, let's talk about stomach ulcers for a little bit here. Peptic ulcer disease. We can have ulcers of the esophagus, ulcers in the stomach, or ulcers in the duodenum. There's a number of different causes for that. Obviously, bleeding ulcers can become problematic in terms of chronic blood loss leading to anemia or acute blood loss leading to shock, as well as perforations of the esophagus, stomach, or small intestine can become life-threatening surgical emergencies. So you can see the normal stomach epithelium on the endoscopy. Actually, what we're looking at here is the junction of the esophagus with the stomach. So if you look deeper into that view, you can see where the rugae, or the folds of the stomach, come into play. So we're really at the junction here between esophagus and stomach. You can see those rugae and folds of the stomach in the cartoon, but also in the post-surgical specimen, and notice that big ulcer within there. And then you can see a bleeding ulcer, large bleeding ulcer on the endoscopy. So in peptic ulcer disease, we're referring to gastric and duodenal ulcerations of the GI mucosa. About 80% of individuals with one of these will be symptomatic, typically having that epigastric dyspepsia pain, usually referred to as burning or type of hunger or growling pain. Some of these are food provoked. Some of these get better a couple hours after eating. So food provoked pain is typically gastric pain, which improves a couple hours after eating, or more commonly duodenal. Pain doesn't mean that you've got peptic ulcer disease, and an absence of pain doesn't mean that you don't have peptic ulcer disease. Some patients complain of back pain or periumbilical pain as opposed to epigastric pain. Some individuals have silent ulcers, where they've got an ulcer but they're not experiencing pain. This is something which is a little bit more commonly in the elderly, and I believe also in adults with diabetes. Individuals who have functional dyspepsia, so they've got ulcer pain, but they lack any type of organic pathology or lack an ulcer on a endoscopy. Sometimes that's referred to as functional dyspepsia. But an individual has persistence pain, worsening of pain despite pharmacologic intervention, an individual who's got GI bleeding, either in the form of hematemesis, throwing up blood, guaic-positive stools or melena, individuals found to be anemic, unable to eat due to pain, losing weight. These would all be risk factors for more severe pathologies, including ulcerative cancers. Let's look at that. So the gastric mucosa is protected by a superficial mucus alkaline layer. And making that mucus alkaline layer is dependent on a product referred to as prostaglandin E. If that mucus layer wasn't there, when acid reached those epithelial cells, that would become destructive. So we want to protect the stomach against its own acids, and the way that we do that endogenously is by those cells that secrete that alkaline mucus, and that alkaline mucus is dependent on prostaglandin E stimulation. So what are some things that can cause ulcers of the esophagus, stomach, or duodenum? A common one is a bug called H. pylori, which we'll look at in a second here. Drugs, particularly non-steroidal anti-inflammatory drugs and glucocorticoid steroid drugs like prednisone, they all decrease the synthesis of prostaglandin E, so we lose that mucus protection. Alcohol and tobacco. Stress, you've seen this if you're working in an ICU unit, particularly trauma patient, burn patients, or anybody who's been in there for a long period of time for whatever reason. Some individuals have hypersecretory tumors that secrete gastrin. Remember, gastrin is a stimulus to the proton pump. All of these things can lead to lack of GI protection or increase in gastric acidity, leading to breakdown of that superficial mucosal layer, leading to ulcerations. So here we see a gastric ulcer again in a couple of our endoscopy photos. Again, we can see the normal endoscopy and then two of them with ulcers, and one of the prime causes of ulcerations, particularly in the stomach and duodenum, is this bacteria referred to as Helicobacter pylori. So let's talk about him for a minute here. Helicobacter pylori, discovered in 1982, is classified as a gram-negative organism. It's able to survive in the GI mucosa by burrowing into the mucosa. It's microaerophilic, meaning it only needs a little bit of oxygen tension. It secretes a compound called urease, which forms an alkaline protective layer around itself. And again, as it burrows in, it also creates a biofilm around itself, which protects it against gastric acidity. That bacteria, as it burrows into the GI, into the stomach duodenal epithelium, can lead to mucosal destruction, eventual atrophy of the mucosa, and can actually produce precancerous lesions. Many individuals are colonized, but most individuals are asymptomatic. Center for Disease Control says there's about a lifetime prevalence of about 10 to 20% of the population developing H. pylori-induced illness. And because of the type of bug it is and where it is, getting rid of it with antibiotics can be difficult. In the photo, you can see on the left, in that particular biopsy of the stomach, you can see a stain, and you can see that stain has picked up all those bacterial cells. The H. pylori bacterial cells kind of take on a kind of like a dark purple, almost grayish appearance, and you can kind of get a sense that they're burrowing into the gastric epithelium. And then you can see the negative sample on the right. So there's a couple of different ways that we can test for the H. pylori antigen in terms of finding it in stool, finding it in urine, doing a serum antibody test for it. An endoscopy can be done, where then a biopsy can be stained or the organism can be cultured. There is a certain gene that H. pylori can possess, referred to as a cage A gene. Bacteria that have that gene tend to be more virulent or more likely to cause disease, invade, and cause ulcers versus just being superficial. And you can look this up. We're not going to talk a lot about this. We'll save this for pharmacology class. Getting rid of H. pylori, if diagnosed, can be difficult and often requires a regimen of 3 and sometimes even 4 antibiotics to eradicate it. If you've treated anybody with a documented H. pylori gastric ulcer, you know that they can be on medications for weeks. They can be taking antibiotics for weeks to fully eradicate that bug. So complications of peptic ulcer disease, obviously GI bleeding can lead to anemia. GI bleeding can lead to hypovolemic shock. The ulcer, as it heals, can lead to scarring and fibrosis, which can lead to stomach outlet obstruction or proximal duodenal obstruction. Peptic ulcer disease can lead to anorexia, persistent vomiting, and eventually malnutrition. And peptic ulcer disease can also lead to gastric cancer. So look at the 3 surgical specimens here. Look at the endoscopy. Look at the surgical specimen of the stomach being removed. And then look at the specimen in the pathology lab, and you can see that those ulcers can become extremely large and extremely devastating. So what's the difference between peptic ulcer disease and gastric cancer? Obviously, gastric cancer would show the anaplasia in the GI epithelium. Risk factors for gastric cancer: age over 55, smoking. Symptoms: individuals who are losing weight, individuals who are having significant pain while swallowing and eating, individuals throwing up blood, individuals who are anemic, very similar to the risk factors and symptoms that we saw with esophageal cancer. It may be difficult to delineate it as being esophageal versus gastric solely based on history and physical exam. So again, the role of the upper endoscopy of the EGD and biopsying ulcerative lesions to make that diagnosis of peptic ulcer disease versus actual adenocarcinoma of the stomach. And you can see that there's a lot of different ways that we can neutralize stomach acid. Remember, I talked about that a little bit earlier. So antacids like magnesium hydroxide, calcium carbonate, they just immediately neutralize the acid. Agents like Pepto-Bismol coat the GI mucosa and protect the GI mucosa against the acid. You can use drugs which are antagonists to histamine. Those are referred to as the H2 blockers. And then you can use drugs that directly block the proton pump, such as the Prilosec or Nexium. Of these 4, which is the one that we should not be using for kids? That is the Pepto-Bismol, right? Because of salicylate. Remember that we tried to avoid using aspirin for sure, acetyl salicylate. That's the problematic one with kids. Of these 4, probably shouldn't use bismuth salicylate in children either. But the antacids, the H2 blockers, and the proton pump inhibitors, definitely safe. Mention vitamin B12. Remember, vitamin B12 is necessary for a number of different metabolic reactions, particularly reactions that involve the building of the bases used for DNA synthesis. We use B12 for growth, forming myelin, forming red blood cells. B12 is primarily found in animal foods. B12 has to bind intrinsic factor. Remember, intrinsic factor comes from the GI mucosa, and that B12 intrinsic factor complex is absorbed in the ileum of the small bowel, so they're absorbed together. And then B12 can be stored in the liver and released as needed. Individuals who have had severe gastric pathology, who have had resections of the stomach, are deficient in intrinsic factor. By not having intrinsic factor, they cannot absorb vitamin B12, and that inability to absorb vitamin B12 is referred to as pernicious anemia. So those individuals then become dependent on vitamin B12 injections. So if you inject the vitamin B12 into them once a month into the muscle, they can absorb that B12, but individuals with stomach pathologies who are not making intrinsic factor won't be able to absorb dietary B12. All right, let's talk a little bit about vomiting now. So vomiting initiates in a part of the brain in the pons referred to as the chemoreceptor trigger zone. And different inputs come into the chemoreceptor trigger zone, inputs from the GI tract, through our senses, through the vestibular system, to the cerebral cortex, and they all converge here in the pons and activate one of 4 different receptors: histamine, dopamine, acetylcholine, or serotonin. The H1 receptor for histamine, the D2 receptor for dopamine, the muscarinic M receptor for acetylcholine, and the 5-HT serotonin receptor. And antiemetic drugs are antagonists to those receptors. So an individual with nausea and vomiting, we can use an antagonist drug to histamine, dopamine, acetylcholine, or serotonin and provide some antiemetic relief. Cannabidiol, one of the products found in marijuana, is also a very effective antiemetic as well. Has a little bit different mechanism of action versus those 4 neurotransmitters, but again, another pharmaceutical means to inhibit vomiting is by using a component of marijuana, specifically the cannabidiol. So here I've summarized for you a number of different antiemetic drugs and their mechanism of action, the drugs that fit in that class, and some potential adverse effects you might see with those drugs. So this will be beneficial for you for pharmacology. Of course, in terms of testing in this unit, I might ask you mechanisms of action or understanding something about the chemoreceptor trigger zone, but this is really here, the slide's really here for your information to see what are the different products that are available in terms of antiemetic therapy. Another one I didn't talk about are drugs that block this NK1 receptor, a prepitant. That might be a drug that you only see if you're working in oncology for people who have really severe nausea, vomiting due to chemotherapy. So there's a lot of etiologies for vomiting. Remember, in an individual who's vomiting, always think about non-GI tract etiologies. So if someone is found to have a headache and cranial nerve palsy, hopefully you would be thinking intracranial pressure. If somebody is vomiting after coughing and you hear rales in their lungs, hopefully you're thinking pneumonia. If someone is hyperglycemic and breathing fast, maybe you're thinking DKA. An individual who's vomiting, who's also having urinary issues, think urinary tract infection. Person who's vomiting after coughing and wheezing, that might be an asthma exacerbation. Person who's vomiting who's got exudative pharyngitis, that might be due to like strep throat or mono. People who are losing weight and won't eat, maybe their vomiting is self-induced, such as anorexia or bulimia. So again, when you're evaluating an individual with vomiting, that might be coming from the GI tract, it might be coming from other organs as well. So thorough history, good physical exam. Think about all the different things that can cause vomiting. And then how can you characterize an acute surgical abdomen versus a medical cause of vomiting? So think about this person who's throwing up blood or bile, the person who continues to vomit despite being NPO, the individual with the distended firm abdomen, localizing tenderness or peritoneal signs, involuntary guarding. If you find something like an incarcerated hernia, the individual had trauma, I would be thinking surgical abdomen. I'd be thinking some type of surgical disaster, which is causing that individual to be puking, such as appendicitis or small bowel obstruction. On an abdominal KUB, you may see distended air fluid loops. You may see free air. Individuals having medical causes of emesis, they still may puke blood or bile, but that individual may be able to tolerate clear fluids. Usually the abdomen is non-distended and soft, no rebound findings, no guarding. And the KUB may be non-specific in that there could be air and gas scattered throughout, but you don't see anything suggestive of an obstruction. So there's a lot of things you got to think about in an individual who's vomiting. Is it from the GI tract or not? If you think it's coming from the GI tract, is it surgical versus medical? Let's look at some x-rays here. So we've got a normal KUB on the left showing you some non-distended distribution of bowel gas, proximal all the way distal, all the way into the rectum. And then on the other four KUBs, you can see a lot of dilated, distended air fluid loops. And when you see those dilated, distended air fluid loops, particularly in an individual who may be vomiting up bile, then definitely think some type of surgical entity as a cause of that vomiting. All right, let's move on and keep moving through the GI tract now, and let's talk about the small intestine. So when we leave the stomach and go through the pyloric sphincter, we're in the first part of the intestine, that C loop. The C loop, or the duodenum, is where we're going to get secretions from the liver and from the pancreas. And those secretions, such as bile from the liver, and pancreatic fluid containing pancreatic enzymes, are going to be helpful in the chemical digestion process. The next part of the small intestine will be the jejunum, and the final part of the small intestine will be the ileum, where the majority of nutrient absorption occurs. So again, we can see the anatomy of the stomach, pylorus, and the C loop of the duodenum. Ducts from the gallbladder and from the liver are going to carry bile into the duodenum, and the pancreatic duct carrying pancreatic juices and pancreatic digestive enzymes are also going to come through a duct and end up in the duodenum. Where the hepatic duct and where the pancreatic duct meet is referred to as the sphincter of Oddi, ODI. And again, that's emptying into the duodenum, putting in necessary secretory components for chemical digestion of food. In the jejunum and the ileum, this is where we're going to actually see the majority of the chemical breakdown of the food and the majority of the absorption of the nutrients. And then from the ileum, we're going to go into the large bowel at the cecum. So let's talk about the pancreas for a second here. We talked about the pancreas with respect to its endocrine function, right? We talked about insulin and glucagon and the incretins. Now let's talk about the pancreas with respect to its exocrine function. So the pancreas is a solid organ, but it's got this hollow duct running through it, and that duct empties through the sphincter of Oddi into the duodenum. The exocrine portion of the pancreas makes the majority of our digestive enzymes. Those enzymes, along with alkaline fluid, are secreted by those exocrine cells, also referred to as acinar cells, A-C-I-N-A-R. Those cells are secreting their products into the duct, and then those products are carried to the duct to the duodenum. Enzymes that we have coming out of the pancreas are digest proteins such as proteases and peptidases, digest fats such as lipases, digest carbohydrates, amylase, lactase, maltase. They digest DNA, digest phospholipids, and digest steroids. So there are a number of different types of pancreatic enzymes necessary to digest all the different types of plant and animal material which we are eating. And here again, this slide is just summarizing for you the different enzymes that we use to digest carbohydrate, protein, and fat. A lot of that is coming from the pancreas. So chemical digestion involves taking large nutrients and breaking them down into the smaller nutrients, breaking down the carbohydrates into monosaccharides, breaking down the proteins into amino acids, breaking down the big fats into smaller fatty acids and triglycerides. And those small nutrient molecules then are going to be absorbed by the intestinal epithelium, primarily found in the jejunum and the ileum. If you look at the mucosal surface of the small bowel, you can see that it has a number of these projections referred to as microvilli. And these microvilli increase the surface area, so we've got more surface area available to break down and absorb these nutrients. So we don't absorb big nutrients. We don't absorb big carbohydrates and big fats and big proteins. We got to break those down chemically into small molecules such as glucose, amino acids, and the small fatty acids. Microvilli on the epithelial surface of the small intestine can also produce these digestive enzymes. We can refer, another term for this absorptive surface is referred to as the brush border. So those small molecules got to come through those epithelial cells and be absorbed into the blood vessels of those microvilli, and then that absorbed nutrients going to be carried into the blood and primarily going to go to the liver. So when we talk about the liver, we'll complete that digestive process. Remember, we have lacteals in these microvilli, and we talked about fat digestion and fat absorption in the cardiovascular units. Remember, some of that fat is going to be absorbed through the lacteals in the lymphatics. And here again, here's a review of fat digestion. So take that beautiful bacon cheeseburger there, which is using a Krispy Kreme donut as a bun. Have you ever done that? You ever made a burger using a Krispy Kreme donut as the bun? Man, it is amazing. So a lot of fat there, right? And remember that bile is coming from the liver. We use bile in the emulsification and the digestion of those big fats. Bile is made in the liver, it's stored in the gallbladder, and then when we eat a fatty food, the gallbladder will contract and release that bile through the duct, through the sphincter of Oddi, and into the duodenum. Bile, along with the lipase enzymes, will be responsible for fat digestion. And as we break down that big fat into the smaller fatty acids, triglycerides, then they're absorbed through the brush border of the epithelium and into those lymphatic lacteals. Here's an important enzyme that we use in the digestion of carbohydrate, and that is lactase enzyme. Lactase enzyme breaks apart lactose sugar. Lactose sugar is a disaccharide made up of galactose and glucose. We typically don't absorb lactose as the disaccharide. We need to break it down and absorb the glucose and the galactose sugars. And lactase enzyme, produced at the microvilli brush border of the small intestine, is responsible for that process. Now we have individuals who have what's called lactose intolerance, and they are lactose intolerant because they lack the enzyme lactase for breaking down that sugar. Lactose is primarily found in dairy products, particularly cow's milk. So we lose lactase with age. A lot of elderly folks become intolerant to milk and other dairy products because they're losing lactase with age. Some individuals have a congenital deficiency of the enzyme. Anything that leads to inflammation of the bowel mucosa, particularly viral infections, can temporarily reduce the synthesis and release of lactase enzyme, and that can further lead to problems with absorption of nutrients while the individual has the acute inflammation or the chronic inflammation going on at the small border, at the brush border of the small bowel. So symptoms then are due to inability to absorb that carbohydrate. Bacteria will act on that carbohydrate, and the individual then will develop gas, bloating, and diarrhea, fairly common symptoms of lactose intolerance. Managing it, avoid lactose, and there are a number of different lactose-free products that the individual can use, and there's lactase supplementation, where yeast is placed into the supplement, and then you're using the yeast lactase enzyme as a means to absorb and break down the dietary lactose. Still talking about the pancreas, let's talk quickly about pancreatitis or inflammation of the pancreas. This can be acute or chronic. There are many etiologies. One of the most common cause of acute and chronic pancreatitis is binge drinking, ethanol. Binge drinking ethanol, I'm sure you've seen a number of individuals develop acute pancreatitis. Viral infections, a lot of different drugs can cause inflammation of the pancreas, particularly nonsteroidals, chemotherapy, a variety of different antibiotics and anticonvulsants, gallstones, disorders of lipids, elevated calcium levels, trauma, radiation. So what's going on? All these different things are damaging the pancreas, leading to inflammatory responses. That inflammatory response leads to damage of the organ due to secretion of those active enzymes, particularly the protease enzymes and the lipase enzymes. That can lead to protein destruction of the pancreas, and it can lead to fatty necrosis of the pancreas. And over time, acute pancreatitis and chronic pancreatitis can either become hemorrhagic, which is clearly life-threatening, or lead to development of cysts on the pancreas as well. Treating acute pancreatitis. So this can actually become life-threatening, and some individuals may require emergent surgery. Management includes keeping the person NPO, vigorous IV hydration. If they're NPO for a long period of time, they may require TPN. Individuals who develop severe pancreatitis can get profoundly hyperglycemic and may require insulin even if they're not diabetic. Analgesics are important, as this can be fairly painful. Acid suppression of the stomach is important, usually done with the IV proton pump inhibitor Protonix. If the individual has an offending agent causing this, you want to stop that drug. And surgical consultation, extremely important for individuals admitted with severe pancreatitis. Serum amylase and lipase enzymes may be important in making the diagnosis, as those enzyme levels will get markedly elevated from pancreatitis. X-rays, ultrasounds, ERCPs, more sophisticated diagnostic testing can be done to not only confirm pancreatitis, but look for things like obstructions in the duct, look for cysts. People with chronic pancreatitis may need to do a significant amount of lifestyle modification in terms of avoiding risk factors, particularly ethanol, may require long-term analgesia, may require long-term specialty diets, tube feeding or hyperalimentation, fat-soluble vitamin replacement, and a lot of individuals may need to be on some form of pancreatic enzyme replacement. So there's one type, there's a number of different types of capsules that contain dried enzyme. Here's one of those products called Creon. The individual may have to take anywhere from 1 to 4 of these tablets every time that they eat, and those tablets then contain various combinations of all those different enzymes. So when they eat food and take the tablet, then they're essentially taking that tablet and releasing that enzyme into the duodenum, allowing the enzyme to do its chemical digestion on the nutrients which they've ingested. Pancreatic cancer accounts for about 3% of all human cancers, about 7% of all human cancer deaths. You can see about 25,000 or more new cases annually. Most primary cancers of the pancreas are adenocarcinoma, but you can see that there's some other different types of cancers and some other different types of non-malignant tumors, such as cysts, which can occur on the pancreas. Risk factors, male to female ratio is about equal. Age greater than 60, individuals who smoke, who are obese, who are Black, African American, family history, individuals with underlying cirrhosis, type 2 diabetes. Other risk factors may include alcoholism and diets which are high in processed red meat, and individuals who carry certain oncogenes such as the BRCA or the MSH mutations may also be at increased risk of pancreatic cancer. When do we consider pancreatic cancer? So individuals who fall into these high risks, who have chronic abdominal pain, individuals who have palpable abdominal masses or distension, chronic pain with weight loss, individuals with unexplained jaundice, individuals who have acute cholecystitis or chronic inflammation of the gallbladder, obstruction of the gallbladder may be due to a tumor in the pancreas, particularly at the sphincter of Oddi. That's where ERCP can come in handy, looking at the endoscopy, which is going through the duodenum and looking up at the sphincter of Oddi for obstructive lesions. And then imaging such as ultrasound, abdominal CT, just talked about ERCP. So a lot of different imaging, medical imaging and diagnostic procedures which can be done to look for obstructing lesions within the duct of the pancreas. Let's talk now a little bit about celiac disease. Celiac disease is an immunologic reaction which is triggered by the protein gluten, and that immunologic reaction occurs on the epithelium of the small bowel, also referred to as celiac sprue. I've seen variations on the epidemiology of this, where some sources say anywhere as much as 10% of the population has gluten sensitivity to less than 1% of the population having the true disease. This is a T-cell mediated destruction of the microvilli, and that leads to impaired absorption of nutrients, particularly lipids. So another thing that you could refer to this disease to is gluten enteropathy, where enteropathy means pathology of the enteric bowel, the small bowel. So if you look at the lower picture, what's happening is the protein of gluten, the gliadin protein, is able to move across the brush border of the epithelium without being fully digested. That protein, as it moves through the brush border of the cells, gets recognized as a foreign antigen, and that triggers a T-cell response. Those T-cells then destroy the epithelial surface of the brush border. And as you recall, the brush border of the epithelial surface is where nutrient absorption is occurring. That brush border is also where digestive enzymes are being produced. So if you lose that brush border, you end up with serious compromise to absorb nutrients, primarily fats, but a number of nutrients are not absorbed in individuals suffering from celiac. So what is gluten? Gluten is actually a plant protein, and it's a small protein made up of two peptides, gliadin and glutenin, and those peptides are really high in glutamine and proline amino acid content. So you can see those two amino acids, glutamine and then proline, next to it on the right. So gluten is a combination of these two smaller peptides with high amounts of those amino acids. And that gluten is primarily found in the endosperm of the wheat kernel. When you look at flour, flour is processed from the endosperm only, where whole wheat is processed from the entire kernel. So an individual who wants to follow a complete gluten-free diet has to avoid anything with that peptide in it, including wheat, rye, barley, oats, and all types of processed wheat flours. So substitutions for gluten then can be flours made out of rice, potato, soybean, or quinoa. And quinoa is pictured on the lower right. It's actually a plant native to South America, and the seeds are harvested, and those seeds then is what are cooked as the quinoa. Kind of looks like a weed to me. And for the longest time, I used to laugh at quinoa until one day some students of mine actually made some that was really, really good. So now, even though I don't consider myself to be gluten-free by any means, I do find myself purchasing quinoa and using it. It's actually not that bad. Okay, so celiac disease usually starts in childhood, usually when cereals are added into the diet. And again, if those cereals contain wheat flours or any of those other types of grains in it. the child will develop diarrhea as a result of the enteropathy, and then as part of that diarrhea, losing fat-soluble vitamins, and the child will start developing complications of that, including malnutrition. Celiac disease can also occur later in life. So it's a malabsorptive disorder, and it's an autoimmune disorder. And one of the ways which is diagnosed and suspected is by the individual having steatorrhea, which is diarrhea due to a lack of fat absorption. So a lot of fat shows up in the stool. One of the ways that this used to be diagnosed was the individual would collect stool for 72 hours, and then they would do a quantitative analysis of the fat. Now it's suspected more easily on a stain of the feces, and that stain is specific for fatty oils. That's called a Sudan orange stain, and you can see that stain in the upper photo showing you those oily orange droplets. But now endoscopy and biopsy of the microvilli is a confirmatory means to diagnose celiac disease. So in the middle picture, you can see a healthy small intestine, and in the individual suffering from celiac disease, you can see how that small intestine microvilli has been lost. And again, that's due to the T cell autoimmune process, which is attacking it. Even easier way now to at least suspect celiac disease is to do antibody testing in what's often referred to as a celiac panel. So a blood test is looking for specific IgA antibodies associated with celiac disease. So anti-tissue transglutaminase and anti-endomysial antibody are two antibodies which can be detected in individuals with celiac disease. Complications of celiac disease. So you get steatorrhea, and you get that fatty diarrhea due to not absorbing it, but the lack of inabsorption of fat can also lead to weight loss, particularly failure to thrive in children. Vitamin D deficiency can lead to osteopenia, osteoporosis, inability to calcify dental enamel. Loss of cholesterol can lead to female infertility and miscarriage. Remember, you need cholesterol to build the sex steroids, particularly estrogen and progesterone. So if they are deficient in those two steroid hormones, inability to conceive and carry a pregnancy can occur. And then again, from a lack of absorption of other dietary nutrients, other adverse effects can occur, such as iron deficiency anemia, zinc deficiency dermatitis, B12 deficiency anemia and peripheral neuropathy, and B6 deficiency seizures. So there's an interesting, if you look up celiac disease, University of Chicago Celiac Disease Center, you can read more on the epidemiology of this if this is something that you're interested in. You can see that the incidence is higher in families who already have it. The incidence is higher in individuals who have underlying type 1 diabetes mellitus. And in their epidemiology, they state that about 3.5% of the population has some form of autoimmune disease, and celiac disease accounts for about 10% of all the autoimmune diseases which occur in the US. So are you gluten-free? You should be able to pick out products with and without gluten. I think I have a thread on Blackboard where you can discuss your thoughts on gluten versus a gluten-free diet. For me, it doesn't seem to bother me, so I try to avoid eating the processed stuff that comes in packages and boxes, but I love bread and I love beer, kind of like cherry wheat beer. I love cherry wheat beer, so you don't often see me running for the gluten-free beers or the other gluten-free stuff in the supermarkets. Oh well, but that's just me. So let's keep moving on. Okay, diarrhea. Let's talk a little bit about diarrhea. Diarrhea is large, frequent, watery output of feces, and that can lead to extreme fluid and electrolyte loss. I think we talked about hydration already. You know that if you lose more than 15% of your total body water, that can lead to hypovolemic shock and can be fatal. There's 3 types of diarrhea. Take a look at really quickly here. Osmotic diarrhea, due to lack of absorbing a nutrient. That nutrient draws water into the small bowel. That water being drawn into the small bowel leads to watery feces. You see this in lactose intolerance, malabsorption, individuals who are eating high amounts of a non-absorbable sugar, such as sorbitol, mannitol, and corn syrup. These individuals develop watery diarrhea without a fever. Secretory diarrhea is usually due to an infectious organism which alters the permeability of the epithelial small bowel, particularly when those organisms colonize on the small bowel. Chloride ions and water are unable to be absorbed, and that shifting of chloride ions and water into the lumen leads to a watery, mucousy diarrhea with fever. Vibrio, rotavirus, norovirus, and traveler's diarrhea from E. coli are these types of organisms. And then invasive organism, now you've got organisms that not only colonize on the epithelial small bowel, but actually invade through the epithelium, gaining access in the blood and can potentially lead to sepsis. These individuals have that watery mucousy diarrhea with abdominal pain and cramping and fever, and that diarrhea is often bloody. So in looking at individuals with bloody diarrhea, those are the ones that you should be really concerned of with respect to invasive organisms such as Shigella, Salmonella, Campylobacter, and amoeba. Here is secretory diarrhea. It's due to the fecal coliform E. coli. We chlorinate water here in the United States, and we're kind of used to this type of strains of E. coli that we get exposed to. But if you travel to other regions of the world where water is not completely purified, not chlorinated or ozonated, and you get exposed to water with those different types of E. coli species, you could end up with a pretty significant secretory diarrhea syndrome, watery mucousy diarrhea with abdominal pain, cramping, and fever, usually not bloody. And this type of diarrhea from this form of E. coli is usually not invasive. If you look at the world map, you can see the more darker red regions are areas of the world where traveler's diarrhea is much more prominent. So things that you want to do when you visit those places of the world is only use bottled or purified water. That includes the ice that you're using in your drinks. Cook all your foods. Avoid raw shellfish and ceviche, which is kind of like the Mexican form of sushi, if you will. Use reputable food vendors. Try not to eat from the street vendors. And only use dairy products which are known to have been pasteurized. Treatment of this type of diarrhea is usually effective with oral hydration. Bismuth salicylate, Pepto-Bismol. That bismuth actually has antimicrobial effect to it. Ciprofloxacin, and a newer drug, rifaxamycin has also been used in treating individuals with traveler's diarrhea. Now, I'm knocking on wood here because I have a gut that tolerates this pretty easily. I've been to Mexico and a number of different regions in Central America numerous times, and I've really never gotten sick with traveler's diarrhea, and I love to eat ceviche. Again, it's kind of like their form of sushi, if you will. It's raw fish with a lot of lime and salt and other peppers and herbs in it. Really, really good. But I'll keep knocking on wood and keep making those trips, and hopefully I will stay free of that entity. Norovirus is another example of secretory diarrhea. The virus is replicating on the GI mucosa, leading to impaired ability to absorb water. All that fluid gets secreted into the lumen, into the GI tract, and individuals, again, will develop that watery, mucousy diarrhea, often with abdominal pain, cramping, and fever. And once one individual has norovirus, you know that that norovirus can spread like wildfire, not flour, I'm thinking of gluten, wildfire through schools and hospitals and cruise ships and other type of places where institutionalized patients are. I'm sure all of you have, particularly if you've got kids, I'm sure all of you have gone through bouts of norovirus diarrhea. This is cholera due to the organism Vibrio cholerae. We typically don't deal with this in the United States due to the chlorination and ozonation of water that we have. But in many developing and third world countries where water supply gets contaminated and not chlorinated, they get exposed to this organism, Vibrio. And that Vibrio organism not only colonizes the small bowel epithelium, but it actually secretes and releases a protein that activates the chloride ion channel pump. And when it activates that pump, it actually takes chloride out of the cell and pumps it into the GI lumen. And in the GI lumen, water follows. An individual with this disease, cholera, will have massive amounts of watery diarrhea, losing massive amounts of fluid and electrolytes in a very short period of time. And this is what makes it lethal. So in this fictitious story that I have here, how can cholera be lethal in less than 12 hours? If you took a 15-kilogram child, and that child has about 8 liters of water in his or her body, let's say that this individual had 6 stools, which had 300 milliliters of water weight to it. That would be 1,800 milliliters. 1,800 milliliters divided by 8,000 milliliters, that's already 22% of volume loss. And again, remember that 15% of volume loss can lead to irreversible hypovolemic shock. The last big outbreak that I recall of cholera was following the earthquake in Haiti, and more people died of diarrhea than died due to trauma in the actual earthquake. And you can look up cholera on the CDC website and find numbers of incidents of outbreaks of cholera under similar situations. But again, this is something that you just rarely, if ever, would see in the US. And then dysentery, another form for invasive diarrhea. These are the pathogens which can also contaminate food and water, but in addition to colonizing the small bowel, will actually invade through the small bowel, get access into the deeper GI lumen tissue, and potentially access into blood, leading to sepsis. These individuals typically have fever, intense abdominal cramping, pustular bloody diarrhea, and that diarrhea can be sent for culture and sensitivity. The disgusting picture at the bottom there is an infant who is suffering from invasive diarrhea, and you can see the obvious gross bloody mucousy stool from that child with invasive diarrhea. Again, organisms include Shigella, Campylobacter, Salmonella, Listeria, amoebic parasites. These are not all too common in the USA, but they still do occur. If you follow the news, you always find certain foods which are being recalled from the market due to Salmonella or Campylobacter type of contamination. So with respect to stool cultures, not every individual with diarrhea needs a stool culture. The yield on stool cultures is fairly low, the yield meaning finding a positive invasive organism. So if you look at everybody with diarrhea, you're often not going to find an invasive organism. But if you have an individual with fever and bloody diarrhea, those are the ones that you definitely want to culture because they have the higher incidence of these types of invasive organisms. So how about antidiarrheal compounds? Should we be using antidiarrheal medications for individuals with infectious diarrhea? Number one, rehydration is always the priority. If the individual is having malabsorptive diarrhea, then omit the offending agent. If it's lactose and they're lactose intolerant, then stop eating lactose, right? But if it's infectious diarrhea, think of it, diarrhea is usually nature's way of trying to expel that pathogen. So in individuals with secretory diarrhea, and even invasive diarrhea, they're trying to get rid of the pathogen, and using antidiarrheal compounds potentially makes it such that the pathogen stays longer inside the individual in the GI tract. So this may not always be the best idea. Bismuth salicylate, like I mentioned really quickly, inhibits the secretory effect of the small bowel. It also has some antibacterial and anti-inflammatory effect to it, due to anti-inflammatory due to the salicylate, antibacterial due to the bismuth. Loperamide is actually an opioid analgesic, and you know that opioid analgesics impair peristalsis. So by impairing peristalsis, you get constipation. So one way of treating diarrhea is with an opioid analgesic. Loperamide is an opioid which is able to be sold over the counter because the medication found in Imodium, loperamide, does not cross the blood-brain barrier. So it's very difficult to get high from taking loperamide. People try, trust me, I've seen people try to take 20, 40, 50 loperamide tablets and try to get high from doing that. And when you take that much loperamide, well, yeah, you're in for a bout of severe constipation, but you may also get some of that euphoric effect from using the loperamide in clandestine means such as that. And then Lomodal, sometimes you see Lomodal used for individuals who have really severe diarrhea, often people who are suffering from diarrhea due to adverse effects of chronic cancer chemotherapy. Lomodal is a combination of diphenoxylate, which is the opioid analgesic, and atropine, which is anticholinergic. Remember, the anticholinergic drugs inhibit the parasympathetic nervous system. The parasympathetic nervous system drives peristalsis through acetylcholine. Atropine inhibits acetylcholine, so rather than getting peristalsis, you get ileus. So the combination of the potent opioid analgesic and atropine leads to impaired peristalsis. And again, while it may be effective for an individual with chemotherapy-induced diarrhea, this would be a really poor choice for treating an individual with infectious diarrhea. Crosses the blood-brain barrier so that opioid euphoria can be experienced. This is a drug that should not be given to children. The potency of the diphenoxylate combined with the atropine, even small amounts of Lomodal, can result in coma and respiratory depression in children. So a contraindicated drug for kids. All right, let's move on. So we're moving down the GI tract here. Let's talk about the large intestine. So the terminal small bowel, the ileum, attaches to the first part of the large intestine, which is the cecum. At the cecum is where the appendix is found. The cecum is typically located in the right lower quadrant of the peritoneal cavity. So bouts of clinical appendicitis typically present with right lower quadrant pain and rebound peritoneal tenderness. From the cecum, we go up through the ascending colon. We make the hepatic flexure turn, go across the abdomen in the ascending colon. We then make another turn down into the descending colon, and then into the S-shaped sigmoid colon, typically found in the left lower quadrant, and then into the rectum, and then out the mucosal opening, the anus. If you look at the histology of the colon, you see that there's no microvilli. The small bowel epithelium is pretty flat, and it is loaded with mucus-secreting goblet cells. Those mucus-secreting cells putting mucus into the lumen of the small bowel acts as a lubricant to move undigested fecal matter through. The colon has a very, very thick muscular layer, and the colon also has a very thick outer connective tissue serosal layer. That's important because we don't want the colon to perforate. The majority of our potentially dangerous microorganisms or gram-negative microorganisms are in the colon. We want to keep them in the lumen of the colon and not busting through. So having all that muscular layer and having that large serosal layer is protective against colon perforation. So what is the function of the large intestine? Its absorptive function is primarily water and ions. We typically do not absorb nutrients through the colon, but we do absorb a lot of water and ions. It secretes an alkaline mucus. It stores feces in the distal portion. Bacteria that we have in the GI lumen are symbiotic. They actually synthesize some vitamin K and some of the B vitamins for us. And obviously the large intestine controls defecation. There are trillions and trillions of bacteria that we have floating around in the lumen of our GI and the lumen of our colon. Most of those bacteria we have a symbiotic relationship with. A lot of these bacteria are expelled during defecation. At least half of feces is actually bacteria, particularly the gram-negative bacteria, and the most abundant one being E. coli. We talk about the process of defecation. We actually have two sphincters in the rectum. We have the inner rectal sphincter, which is involuntary and controlled by the parasympathetic nervous system. That innervation comes from the distal end of the spinal cord, sacral 2, 3, and 4. And then we have an external sphincter, which is made up of skeletal muscle that is voluntarily controlled. That is not autonomic, that is somatic nervous system, again, voluntary muscle control, but that innervation also comes from sacral 2, 3, and 4. That muscle is usually kept in a contracted state, and then during defecation, both of those sphincters need to open and relax. The relaxation of the external sphincter is something that we do under voluntary control. And that's something that we learn how to control, as young as 2 or 3 years of age when a child is going through toilet training. So both autonomic parasympathetic inputs and somatic skeletal muscle inputs in the process of defecation. All right, one of the pathologies of the colon is constipation. Individuals who can't produce bowel movements. And you can see that there are numbers and numbers of different causes of constipation, from dietary causes to behavioral causes, from inadequate water or fiber in the diet, stress, spinal cord pathologies. Let me just draw your attention really quickly here to medications which are a cause of constipation. Some of the most important medicines, particularly in the elderly, that can lead to significant debilitating constipation include calcium antacids, opiate analgesics, iron supplements, anticholinergic drugs or parasympathetic antagonists, and calcium channel blockers. I think everybody is aware of the constipation that occurs in individuals who are on long-term opioid analgesics, but be aware of these other drugs which can very commonly cause pretty significant pathologic constipation. And again, just look over this fairly long list and be familiar with numbers of different anatomic and metabolic causes as well as behavioral causes of constipation. Again, let me stress anticholinergic medications. So anticholinergic means the drug is having antagonist effect on acetylcholine, and that is inhibiting the parasympathetic nervous system. And in the GI tract, the parasympathetic nervous system is responsible for salivary gland secretion, stomach acid secretion, and peristalsis. So common GI findings of anticholinergic drugs include dry mouth, decreased peristalsis and constipation. Other non-GI findings of anticholinergic drugs include urinary retention, tachycardia, and skin flushing. So antihistamine medications, antidepressant medications, antipsychotic medications, antispasmodic medications all bring with them to some extent anticholinergic effect, making that individual at increased risk of these clinical effects stated on the slide. So be aware of that. We know that opioids are extremely important causes of constipation. Any opioid that a patient is on can lead to constipation. So consider placing patients on laxatives whom you have prescribed opioids or are administering opioid analgesics to. And again, it doesn't matter by what route or which of the drugs they're getting. If they're on an opioid analgesic, they're destined to develop constipation. The effect of constipation due to an opioid is due to the effect on the mu receptor. So the mu receptor is what gives them the analgesia, the sedation, and the euphoria. The mu receptor is what also causes the respiratory depression and physical dependence, but on that mu receptor is also the adverse effect of diminished peristalsis on the GI tract. Managing constipation, usually used with some type of drug that acts as an osmotic cathartic. What do I mean? It's a product that an individual ingests or places into the GI tract via an enema, and then that product draws more water into the lumen, and increasing more water in the lumen makes the stool softer, runnier, and loose, and it's an effective way of unplugging somebody with constipation. So milk of magnesia has magnesium hydroxide. Metamucil has a non-digestible fiber. Miralax has polyethylene glycol, that polymer again acts to pull water into the lumen. Sodium phosphate enemas, saline enemas, same thing, acting as osmotic cathartics, as is Biscadil. Glycerin can have some osmotic cathartic effect to it, but it also is going to be kind of slippery and act as a means to make the rectal mucosa more slippery, right? Kind of like any other jelly would, where things are be able to come out easier without as much straining. So osmotic catharsis, that general mechanism, is an important mechanism in managing someone with constipation, but as you know, it's also important with cleaning out the GI tract, such as before surgery or an endoscopic procedure. Okay, let's talk about colon cancer for a couple of minutes here. It's the third most common type of cancer in males and females. Overall, there's a 1 in 20 lifetime risk of developing colon cancer, and you can see the number of estimated new cases and deaths in the USA as reported by the CDC. Risk factors: age over 50, first degree relative who had it, if your ethnicity is either Black or Eastern European, individuals who smoke, abuse alcohol, are obese or have sedentary lifestyles, individuals whose diet contains a high amount of processed red meat and a low amount of natural plant fiber, certain individuals with inflammatory bowel disease who are already showing signs of abnormal cellular growth on a biopsy or dysplasia. We'll look at that in a couple minutes here. Individuals with type 2 diabetes, individuals with acromegaly, a disorder of too much growth hormone endogenously, or again, people that are using exogenous growth hormone, adults who are injecting themselves or having themselves injected with growth hormone. Vitamin D deficiency has also been associated with colon cancer. In terms of the hereditary component of colon cancer, there are a number of different syndromes and a number of different genetic mutations or oncogenes which are also associated with colon cancer. Question at the bottom there: does a cancer cell typically have one or more DNA mutations? Typically starts with one mutation, one oncogene, but as that cell divides and multiple cells now arise from that cell into a large tumor, usually within the tumor there are multiple types of DNA mutations. Adenocarcinoma is the most common form of colon cancer. Carcinoma, again, meaning epithelium, adeno standing for glandular. So when you looked at that histology of the colon, it's that glandular epithelium of the inner mucosal layer, which accounts for the most types of colon cancers. But as you can see here, there are other types of colon cancers that one can see. You can see the distribution of primary colon cancers. Look at the anus and rectum. So digital rectal exam can determine or can pick up about 1/3 of colorectal cancers, but you can see that some of those colon cancers also occur further down and even all the way back to the right side of the colon in the ascending colon and cecum. Remember that cancers of the GI tract can present as a polyp, they can present as an ulcer, and they have a high degree of lymphatic spread. Picture there is showing you a resected region of a large infiltrative polyp as an example of adenocarcinoma. So cancer is unregulated abnormal growth of abnormal cells. Usually colon cancer begins as a benign, non-cancerous polyp, which becomes a malignant tumor. A polyp is an epithelial growth that protrudes from the mucosal layer. Again, usually starts benign, and then over time, that polyp can transform from one of being a benign epithelial polyp to one of gross malignancy. So we want to pick up polyps and remove polyps, if possible, in the benign stage. And there you can see an example of a colonoscopy of a number of different benign polyps. Those polyps can then be removed in biopsy, looking for dysplasia as a sign of the epithelia converting from benign to malignant. Once it's malignant, then you would find the characteristic anaplastic histologic findings. So very often people are asymptomatic when they have polyps. Depending on the number and the size of the polyps, individuals may experience abdominal pain or change in bowel movement. Tenesmus, which is the feeling of a full rectum. Weight loss, blood in the stool, anemia, and fatigue. Less commonly, I should clarify that. So individuals with polyps are usually asymptomatic, but individuals with colon cancer then can experience those findings that I just went through: pain, tenesmus, weight loss, blood in stool, anemia, and fatigue. Typically, you don't see that from benign polyps. Less commonly, and again, depending on how large that tumor is and what type of tumor it is, bowel obstruction, bowel perforation, or symptoms of metastatic disease. And again, remember, colon cancer, like other GI cancers, have a high rate or high ability to spread via the lymphatics. So screening for colon cancer can be done by digital rectal exam, feeling for distal polyps. It can be done through fecal occult blood, looking for blood in the stool. We're going to talk about the difference between the occult blood test, the fecal hemoglobin test, and the oncogene test in a second here. The most important means for finding and diagnosing colon cancer, particularly in the early stages, is through colonoscopy and biopsy. There is a virtual colonoscopy that can be done, which is a radiologic image. Those are fairly detailed, but you don't do biopsy with that. It's just a imaging, study where the colonoscopy can look directly at the polyps, grab them, remove them, biopsy them. Those you don't do with the virtual colonoscopy. It's just like looking at a CT scan. You can see it. Okay, testing for occult blood. The guaiac test detects heme. Remember, heme is that central iron molecule in hemoglobin. So an individual who is bleeding in the GI tract will release heme into the GI tract, and the occult guaiac test will detect that heme. You can get false positives if the patient is ingesting iron or a lot of red meat. The fecal immunochemical test detects antibodies to human hemoglobin. So this is extremely specific. If it's positive, it means that there is actual hemoglobin or blood in the stool. One problem with the fecal immunochemical test is it only detects lower GI tract bleeding. So extremely effective screen for colon cancer, but not so good if somebody is bleeding proximally and you pick up blood and stool as a peptic ulcer disease or bleeding gastric ulcer, this one will be negative. So the occult guaiac test can give you false positives, but it will detect blood from both upper and lower sources. The fecal immunochemical test is very specific, but only detects blood from lower GI tract bleeding. And currently, now I don't do internal medicine as part of my practice, but as I understand it, the American College of Gastroenterology is suggesting that the better office test for GI bleeding due to colon cancer is the fecal immunochemical test. And then the newer test on the market, Cologuard. This is a test where stool is collected at home. It's shipped back to the company, and then that company actually can not only detect fecal hemoglobin, but also can detect a number of different mutations of genes which are associated with colon cancer. So if the person has a malignant polyp, which is losing and secreting cells, those cells and their DNA can be found in stool. And if you isolate some of those DNA mutations, then that would be a good non-invasive screen for finding an individual with a malignant polyp or colon cancer. The company who makes Cologuard is actually from Madison, Wisconsin, if any of you were aware of that. So 3 tests can be used: the occult blood test, the fecal immunochemical test, or Cologuard. And I have a thread up on Blackboard in which you can discuss which of these tests or combinations of these tests may be used or recommended if you are working in either a primary care or other GI specialty clinic. So just have a basic understanding of the differences between those 3 screens and understand that only in the Cologuard test, that is the one that's the newer test, and that is the one that's actually looking for certain DNA mutations associated with adenocarcinoma of the colon. And here's some examples. So you see the normal colon in the upper left. You can see what they call an adenomatous polyp, the histology of a glandular polyp. On the lower left. And then when you move over to the right, you can see examples of both invasion and a high degree of anaplasia in a confirmed adenocarcinoma of the colon. All right, let's talk a little bit now about the difference between IBS and IBD. IBS, irritable bowel syndrome; IBD, inflammatory bowel disease. Irritable bowel syndrome, also known as spastic colon, affects as much of 20% of the U.S. Adults. These are individuals who have chronic GI complaints such as cramping, pain, bloating, gas, diarrhea, and constipation. And these individuals do not have any discernible, obvious anatomic pathology. These individuals may be symptomatic due to triggers such as certain foods, stress, or hormonal influences. Tends to affect women under the age of 45 more commonly. Some of these individuals have underlying mental health illnesses. Some of these individuals have a high amount of stress. Some of these individuals are potentially involved in abusive domestic situations. These individuals have recurrent, predictable, GI symptoms, one thing that you typically do not see in IBS is blood in stool and involuntary weight loss. Management is trigger avoidance, behavioral modifications, understanding which foods work well with the individuals and which don't. Some people are highly sensitive to things like certain fats, cabbage, dairy products. Stress management plays a role in treating individuals with IBS. Certain drugs such as antiemetic drugs, antidiarrheal drugs, drugs for treatment of constipation may be beneficial. Because there's no discernible anatomic pathology, and particularly no inflammatory component on the GI tract, these individuals are not managed with anti-inflammatory drugs, not managed with steroids, and not managed with monoclonal antibodies. A number of complementary and alternative practices seem to be fairly effective for relieving a lot of the GI tract symptoms that individuals with long-term chronic IBS experience. Let's compare that to IBD, inflammatory bowel disease, and the key word here is inflammation. Individuals with IBD have not only gross, visible to the naked eye, but also microscopic histologic inflammatory changes in the GI tract lumen. Two forms of IBD are Crohn's disease and ulcerative colitis. Crohn's disease occurs anywhere in the GI tract. Ulcerative colitis only occurs in the colon. Crohn's disease can affect the entire wall of the GI tract, so transmural from epithelium all the way to serosa. Ulcerative colitis typically only involves the epithelial surfaces. Crohn's disease has what's referred to as skip lesions. So you have a segment which is affected, then a normal segment, then a segment which is affected, then a normal segment. Where in ulcerative colitis, the segment is affected continuously. You don't see those skip lesions. And again, most of the time that's confined just to the colon, particularly the distal colon. Symptoms include abdominal pain, blood in the stool, weight loss, fatigue. IBD is an autoimmune inflammatory disease. So therefore, individuals with IBD also have other associated inflammatory findings such as arthritis, hepatitis, and dermatitis. Those inflammatory lesions of IBD can be found on upper and lower endoscopies. Inflammatory lesions are not found in individuals with IBS. So IBS versus IBD, individuals with each can experience signs and symptoms that we have in the left: cramping, bloating, flatulence, anorexia, nausea, vomiting, diarrhea, constipation, and fatigue. But individuals with IBD will also experience bloody stools, fever, involuntary weight loss, rash, arthritis, hepatitis, development of abscesses and fistulas, particularly in the perineum and anal rectal area, and anemia. Again, IBD, inflammatory disease. Confirmatory tests for IBD is endoscopy and biopsy. We've talked about some autoimmune antibody testing which can be done for things like celiac and diabetes, type 1 diabetes and lupus. As far as I'm aware, at least at the time of this dictation, there's no common antibody, autoantibody, which can be tested for in the blood in patients with IBD, either Crohn's or ulcerative colitis, unlike other autoimmune diseases where you can find some of those autoantibodies. And now examples of endoscopies of Crohn's disease. On the left, in ulcerative colitis. on the right. So remember, in Crohn's disease, it's usually full thickness and discontinuous. They refer to that as a granuloma, where in ulcerative colitis, it's usually confluent. You don't get those skip lesions, and the inflammatory pathology are mucosal ulcerations. And then we talked a little bit about monoclonal antibodies. Monoclonal antibodies are used for treatment of IBD, never for IBS. Why not for IBS? Because there's no autoimmune inflammatory component of IBS. But in either Crohn's or ulcerative colitis, drugs which neutralize important inflammatory mediators such as tumor necrosis factor, integrin 4, these monoclonal antibodies can be very effective in managing individuals with IBD. So the first one on the market was Remicade and infliximab against TNF. Maybe the most popular one used now in 2018 is Humira. Adalimumab, again, against TNF-alpha. Cimzia is another monoclonal antibody against TNF-alpha. And a newer monoclonal on the market now, Cyrabi, is hitting a different mediator of inflammation. It's neutralizing another protein cytokine, integrin 4. So again, important, using this for IBD patients, never for IBS patients. So both IBS and IBD patients can have pretty significant severity, and both of them can require a number of different types of long-term supportive measures, such as pain control, hydration, nutrition, particularly with supplements, the possible need of G-tube feedings or other IV hyperalimentation feedings. Enteral antibiotics to prevent bacterial overgrowth may be useful. Rifaximin, Xifaxan is a newer antibiotic on the market whose indication is for bacterial overgrowth. Sometimes you may see that in certain individuals with IBS or even IBD. So I guess the point of this slide is that both of these types of patients can require fairly significant supportive GI care, including pain management, but anti-inflammatory management, monoclonal antibody management, and other immunosuppressive therapy is only given for patients with IBD. We have to spend a little bit of time on the liver, so let's do that. It is the largest solid organ of the human body, located in the right upper quadrant. There are 4 lobes to the liver, weighs about 3 pounds. Here it says the second largest organ. Skin is the largest organ. Liver is the largest solid organ. The liver should be smooth and non-palpable. Maybe you can feel the edge of some people who have a healthy liver. If you percussed out the liver on a physical exam, it would be about 8 to 10 centimeters in the mid-clavicular line. The liver, interestingly, has a dual blood supply. So one form of blood flow into the liver is from the hepatic artery, bringing in oxygenated blood. That hepatic artery is a branch off of the dorsal aorta. The second vessel bringing blood into the liver is the hepatic portal vein. And the portal vein brings the venous drainage from the stomach, small bowel, and the large bowel to the sigmoid colon back to the liver. So actually from the lower esophagus to the sigmoid colon, that venous drainage will go first to the liver, and then that blood will flow to the liver and then get back into the vena cava to get back to the right atrium. So dual blood supply, and you'll see the importance of that when we talk about liver pathologies. So going on with this dual blood supply, look at the photo in the upper right, and you can see the hepatic artery going into the liver, bringing oxygenated blood. You can see the portal vein coming into the liver with the blood supply from the GI tract, from the lower esophagus to the sigmoid colon, and then you can see the blood exiting the liver via the hepatic vein. And from the hepatic vein then to the inferior vena cava, and then that blood flow then will return to the heart. Picture on the left shows you the portal venous system. That's that drainage of blood flow from the GI tract through the portal vein and into the liver. So everything that's absorbed from the GI tract initially is going to get into the portal vein and go into the liver first before it hits systemic circulation. So in that bottom bolded statement, following absorption, an ingested drug or a drug taken PO will distribute first to the liver via the portal vein before it gets into systemic circulation. And then in the liver, some metabolism will occur such that some of the drug which has been ingested will be metabolized and often rendered inactive before it even sees systemic circulation. That's referred to as the first pass effect. If you were to look at the liver in terms of the histology, you would see that the liver is separated into small lobules. At the center of each lobule is a vein which is going to go into the hepatic vein. At the edge of these lobules is what's called the portal triad. And the portal triad is a branch of the hepatic artery, a branch of the portal vein, and it also contains a bile duct. So three things within the triad: hepatic artery, portal vein, hepatic duct. And then the blood flow moves from the triad to that central vein, which eventually empties into the hepatic vein. The blood is moving through sinusoids, so spaces between the liver cells. So to get healthy blood flow through the liver, it's got to come in through the triad, hepatic artery or portal vein, and then that blood moves through those sinusoids to the center of the lobule, into that central vein, and then out eventually into the hepatic vein. The lower right picture shows you the portal triad. To the left of that picture, the sinusoids, three zones, 1, 2, and 3, where 1 is closest to the triad and 3 is closest to the central vein. So blood flow is moving out of the triad to zone 1, zone 2, zone 3, and then into that central vein. This is how blood gets into and then eventually out of the liver. So here we show that portal triad, again, hepatic artery, portal vein, bile duct. You can see the blood moving through those sinusoids to that central vein. The bile duct is carrying bile, and that bile is eventually going to be sent out of the liver, stored in the gallbladder, and then released into the small intestine. And again, that bile will be needed for the digestion of fat. So one of the things that we want to talk about with respect to liver pathology is end-stage liver disease, where the liver, due to inflammation, becomes fibrotic, and then a fibrotic, shrunken liver has what we would call cirrhosis. And a number of different things can damage the liver, leading to end-stage failure. One of the most common things is abuse of alcohol, leading to alcoholic cirrhosis or end-stage liver failure due to years of chronic drinking. When the liver fails, multitudes of functions go wrong. The liver is responsible for just numbers and numbers of metabolic functions. Here, the majority of those functions are listed. And again, when liver goes into failure, what you're going to see is dysfunction of all these different metabolic activities. So take a look at this. Exocrine, the liver makes bile, so you'll see a decrease in bile synthesis. Endocrine, the liver is responsible in the activation of vitamin D, conversion of thyroid T3 to T4, the release of IGF-1, the hormone which works with growth hormone. In terms of nutrition, it's involved in both catabolic and anabolic processes, where catabolic processes is the breakdown of substrate into energy, and anabolic processes are taking small nutrients and storing it as larger nutrients, such as glucose to glycogen. The liver makes coagulation factors, so individuals in end-stage liver disease are going to be at risk of bleeding. The liver makes the majority of our serum proteins, including albumin, the lipoproteins that we talked about, such as HDL, LDLs, inflammatory mediators, such as cytokines. The liver is responsible for metabolism, so it metabolizes hemoglobin to bilirubin when red blood cells break down, and it metabolizes amino acids into ammonia and urea, which will eventually be eliminated by the kidney. And then the other major function of the liver is the metabolism of drugs and environmental chemicals. So not only prescription, illicit, and over-the-counter drugs, but any type of chemical that comes into our body either accidentally or unintentionally, the liver plays a major role in the metabolism and elimination of these chemicals. So as you can see, an individual who goes into end-stage liver failure is going to be at risk of scores and scores of different metabolic dysfunctions. So what can injure the liver? Anything that injures the liver is referred to as a hepatotoxin. A hepatotoxin may do a number of different things to the liver. It may directly kill the hepatic cells, refer to that as hepatocnecrosis. It can cause inflammation in the liver, refer to that as hepatitis. It can stagnate bile flow. It could deposit fat in the liver, or it may damage the blood cells of the liver as well. There are scores and scores of different hepatotoxins. In the United States, the three major hepatotoxins, or the toxins most responsible for liver failure, are alcohol, and any form of alcohol. A lot of people believe that it has to be a hard liquor to damage the liver, where beer and alcohol don't damage the liver. I can tell you so many different people that I've encountered with alcoholic liver disease who believe that. All forms of alcohol damage the liver. Hepatitis B and hepatitis C viruses, and the over-the-counter anti-fever, anti-pain medicine, acetaminophen. Mostly known for Tylenol, but as I'm sure you all understand, there are dozens of over-the-counter products which contain acetaminophen. So these are the big three, and we're going to talk a little bit about the viruses, and we'll talk a little bit more about alcohol as we move on as well. Let's begin with acute infection of the liver, or hepatitis. There are various types of organisms that can cause an inflammatory response in the liver. All of these organisms have different severities and different onsets in terms of when they come on. So an individual with one type of liver infection may be a little bit different than a person with a different type of infection. Other things that can cause inflammatory damage to the liver, or I should say there are other things that can cause inflammatory damage to the liver, including the stasis of bile. Bile needs to continually move through the liver. If it stagnates in the liver, that can lead to inflammation. But most of the inflammation, that acute inflammation that we see in the liver, is due to infectious organisms. And we're going to talk about 3 of them, Hep A, Hep B, and Hep C, as we move on. Signs and symptoms of acute hepatitis: fever, fatigue, loss of appetite, nausea, vomiting, and then the individual becomes jaundiced due to the inability to metabolize and eliminate bilirubin. This causes the yellow icteric staining of the sclera and skin, causes dark colored urine, clay colored stools. Individuals with acute hepatitis may have an enlarged liver, hepatomegaly, and then often you see some of the laboratory abnormalities such as elevated bilirubin levels, elevated enzymes such as AST, ALT, GGT, and elevated ProTime and INR. Remember, the liver is making the coagulation factors. So if the coagulation factors are not adequately present, your prothrombin time will go up, making the individual at greater risk of bleeding. And then due to some of the other metabolic dysfunctions which invariably will occur, other metabolic findings that you can see in acute liver hepatitis are low blood sugar, a metabolic acidosis, and not listed on the slide, but you should probably list it, are elevated serum ammonia levels, hyperammonemia. So let's move on and talk a little bit more about the infectious agents. So here we have some photos of acute hepatitis. Upper photos kind of showing you the enlarged edematous liver that you see from acute inflammation. One of the other things that you tend to see in acute inflammation is deposit of fat within the liver. That's kind of shown at the yellow arrow on the top then. And then if you look at the liver microscopically during a bout of acute infectious hepatitis, you will see the engorgement of the liver by the white blood cells. And then the other thing that you will see in the liver is the deposition of fat. And the fat deposition typically looks as clear, big, circular blobs or vacuoles. And you see in that very right lower picture, you see a nice example of a liver very much infiltrated with white blood cells, and you also see that deposit of those fatty vacuoles. So again, looking at the liver both grossly and histologically during a bout of acute hepatitis. 3 viruses we're just briefly going to talk about: hepatitis A, B, and C. Here is Hep A. Hepatitis A comes from ingesting the virus in contaminated food and water, traveling to a high endemic region of the world, having household contacts who are Hep A positive, people who work in or reside as residents in certain institutions such as prisons, group homes, etc., people who participate in anal sex, people who work with vertebrates and research facilities, eating uncooked shellfish, drug abuse. These are all different ways that an individual can get exposed to hepatitis A. Of the 3 big hepatitis viruses, A, B, and C, A does not transmit maternal fetal. An infected person will shed the hepatitis A virus in their stool. Unlike B and C, there is no antiviral treatment for hepatitis A, but there is a very effective vaccine. It's initially given between 12 and 18 months of age. It should be repeated again after 18 years of age. If you are traveling to a high-risk region of the world, it's probably worth receiving that A vaccine again before you travel. But you can certainly give somebody an A vaccine if they've had some type of post-exposure risk. So some behavior or something that resulted in a potentially high risk for contacting Hep A, you can vaccinate the individual again. If you ever got ill with Hep A, you would have natural lifelong immunity. Hepatitis B is a little bit more complex of an organism. It has an outer shell. It has outer protein antigens, one of which is really important, referred to as the S antigen. It has two inner core protein antigens, C and E. This is a double-stranded DNA virus, and it also has its own polymerase enzyme, which helps it copy its nucleic acid, its DNA, once it infects a host cell. The antigen, Hep B S antigen, Hep B surface antigen, can exist by itself in serum of an individual who's been exposed. That S antigen serves as a marker for hepatitis B exposure. The general life cycle of the hepatitis B virus is very similar to other viruses, where it has to attach to the host cell. In this case, it's going to be a liver cell or a hepatocyte. It has to uncoat and release its insides into the cell. It then has to have its nucleic acid copied and replicated. That DNA then is transcribed into the different components of the virus. Those components are reassembled into new viral particles, and then eventually it is released from the host cell to go on to affect other cells. So new hepatitis B viral particles are synthesized once that initial Hep B virus has attached to the host cell and released its DNA into the host cell. We've been seeing a pretty nice drop in rates of hepatitis B virus vaccines in the US since the early 1980s. Reason for that is the aggressive immunization campaigns that we have seen for Hep B vaccinations, particularly in healthcare workers and other high-risk individuals. But still, the CDC says that we've got about 3,000 new confirmed cases per year. The most affected age group is 25 and older adults. We got about 1.5 million people walking around the USA with chronic Hep B, little over 250 million worldwide. Annually, you can see that there's a very significant numbers of deaths which occur worldwide due to Hep B. Many individuals who are HIV positive are also chronic hepatitis B positive as well. This virus now is not transmitted via that fecal oral route as what we see with Hep A, but this one is transmitted parenterally or through human body fluids, blood being the number one body fluid that transmits Hep B. There you can see a number of the different behaviors or risk factors in terms of how an individual can acquire Hep B. Please be aware that this is one where the infant can acquire Hep B from its mother, particularly during childbirth. Sex with an infected partner, sharing drugs involved in drug abuse with infected individuals, direct contact with blood or open sores of an infected person, sharing other types of items such as razors, toothbrushes with an infected person, needle stick exposures, again, very high risk with respect to healthcare workers. But be aware, Hep B is not transmitted through food or water, not through eating utensils, not through breastfeeding, kissing, hand-holding, coughing, or sneezing. Hep B, for those of you that work a lot with blood transfusions and blood products, you know that blood products here in the US are very tightly screened and regulated with respect to hepatitis B. Hepatitis C, another important infectious organism causing hepatitis. This is an RNA virus, but again, like the B virus, also has an outer envelope, proteins on the surface, proteins within the core. And just like Hep B, there are a number of different genotypes or a number of different genes that you can come across with the different strains of both hepatitis C and hepatitis B. World Health Organization estimates that about 3% of the world's population is positive for Hep C, and you can see in that lower global map the distribution in terms of percent of the population with respect to Hep C. In the US, we're in yellow, so we're in one of the lower countries with Hep C. Transmission of Hep C is very similar to hepatitis B, so those same behaviors, those same risk factors. This is one which is not transmitted fecal, oral, or by water or food. Most individuals who obtain hepatitis C have done so through infectious drug abuse or sex with an infected partner. Long before we knew what Hep C was, this used to be deemed non-A, non-B. There wasn't any real screening for it. So back in the 70s and even into the 80s and early 90s, there was a risk of being exposed to hepatitis C through blood transfusions, again, because at that time, Hep C was not identified, and therefore there was no reliable or routine screening of blood products. So individuals who are in the baby boomer population who received blood transfusions back prior to the 1990s are typically the individuals who are most worried about here in the US as being hepatitis C exposed and infected. A fair number of people who get acutely ill with hepatitis C will get better, meaning that they will not go on to progress to chronic inflammation. Individuals who go on to progress to chronic inflammation are at risk of developing fibrosis or Hep C cirrhotic liver, and individuals with Hep C cirrhotic liver have an increased chance in their lifetime of developing adenocarcinoma of the liver. The acute infection with Hep C symptoms are usually mild and contain some of those symptoms that we talked about with respect to general hepatitis: nausea, fatigue, anorexia, elevated bilirubin levels. Hep C has been associated with some non-hepatic syndromes, such as inflammation of the glomeruli and breakdown of red blood cells. Individuals with acute hepatitis C also, in addition to developing inflammation, may also develop some what's referred to as periportal necrosis, or actually death of liver cells in that region around the portal triad. So compared to acute hepatitis A infection, where almost 100% of those cases are going to be self-limited, a number of individuals with acute hepatitis C exposure can go on to chronic forms of the illness. We can screen those individuals by looking for the hepatitis C RNA or looking for antibodies against the hepatitis C virus. Some individuals are going to have a higher ability to clear that hepatitis C and not go on to a chronic infection, and some individuals are going to have a higher risk of going on to chronic infection. So take a look at the differences between these two different lists. Good to understand that people with other underlying chronic liver problems, people who are infected with HIV or Hep B, individuals who are abusing themselves with other hepatotoxins, which includes chronic cannabinoid use, which can lead to biliary stasis, and obviously immune suppressed individuals. These people have a much higher risk of going on to developing chronic Hep C infection. So in terms of screening for this infection, we can look for antibody, anti-hepatitis C antibody, or we can look for hepatitis C RNA. So if you take an acutely infected individual, the RNA, the presence of the virus is there, and then as they develop immunity, you start to see presence of the anti-Hep C antibody. As the antibody goes up, the amount of viral RNA drops. So the photo on the left would be indicative of an acute infection, which resolves. The photo on the right then would be more indicative of a chronic infection, where what happens is the hepatitis C RNA never goes away, and the hepatitis C RNA, indicative of persistence of the virus, remains positive. Despite developing anti-hepatitis C antibody, the viral RNA stays positive, and this is indicative then of an individual that's going on to chronic infection. Okay, then one of the major hepatotoxins is alcohol. And alcohol in and of itself, while it does a lot of things to the brain and the nervous system, alcohol is not as damaging to the liver as are the metabolites of alcohol. So alcohol is metabolized to acetaldehyde and then eventually acetate. And that acetaldehyde is going to initiate processes in the liver that's going to lead to fatty infiltration of the liver, fatty infiltration of the liver, followed by inflammation, and then that inflammation can lead to chronic fibrotic scarring or cirrhosis. So there's stages that an individual goes through who is chronically drinking. There's some stages that they go through before they end up with end-stage cirrhosis, and that is fatty liver to a fibrotic liver, eventually to end-stage chronic destruction, scarring of the liver, referred to as cirrhosis. So an individual who's binge drinking following a fatty diet, and genetics probably play some role in this as well. So some individuals genetically are going to be at higher risk of going on to develop alcoholic cirrhosis than will others. You've probably seen some individuals who've been long-term alcoholics who did not develop cirrhosis, and you've probably seen other individuals in your life who've been binge drinkers and had some degree of alcoholism. But even though they may have less duration of drinking time, they've ended up with end-stage hepatic necrosis. So here we can see the normal liver at the top two photos, showing you the portal triad in the central vein. And again, reviewing for you how blood moves from the portal triad to the central vein. In the lower picture, you can see the early stages of alcoholic liver disease, which is the accumulation of fat, developing the fatty liver, and then inflammatory processes begin, which start to lead to the fibrosis of the liver. So if you look at the picture on the right, you can see the infiltration with the white blood cells. And as you look kind of in the center of that photo, you can see an area that's staining a little more pink, a little bit more dense. That is the initial fibrosis beginning due to the inflammation. So again, alcoholic liver disease progresses from fatty liver to inflammation and fibrosis, and then eventually into overwhelming fibrosis and contraction of the liver, and that end stage is referred to as cirrhosis. And here we can see some photos of normal liver and cirrhotic liver in terms of the gross pathology, the scarring, the contraction, and the lumpy and bumpiness of the liver. And then microscopically, you can see the different staining which is done for fibrosis. So kind of pink on the left stain, and that scarring and fibrosis blue on the right stain, again, proving the point that in an individual with alcoholic cirrhosis, there's a lot of fibrotic scarring which is going on within the liver. So what is the risk of scarring? Remember, the portal triad, blood flow from the GI tract is coming first to the liver via the portal vein, and then that blood needs to move out of the liver by traveling through the sinusoids to the central vein of the lobule, eventually into the hepatic vein, out the liver, into the vena cava. If you have obstruction to the blood flow due to inflammation and fibrosis, then you get stagnation of that blood flow, and that blood flow then backs up into the portal vein, and that's referred to as portal venous hypertension. So you've got a scarred, contracted liver still getting blood flow from the portal vein, but that blood is not moving from the portal triad through the sinusoids and into the central vein. It's not moving through effectively. That blood flow then starts to back up, increasing the amount of fluid in the portal venous system going all the way back to the GI tract. And this is what leads to ascites, the accumulation of fluid in the peritoneal cavity, and varices, particularly in the esophagus and stomach. So the dilation of superficial veins on the esophagus and stomach is referred to as esophageal varices. So these are two significant complications of portal hypertension. Now we're using alcoholic cirrhosis as the example, but understand that anybody from any reason that goes into end-stage chronic liver disease where the liver becomes scarred and fibrotic, those individuals also can develop portal hypertension leading to ascites and esophageal varices. So two major consequences of portal hypertension due to cirrhosis. One will be ascites, the accumulation of intra-abdominal fluid, and the second will be the varices, particularly esophageal and stomach. And each of these can lead to hemodynamic consequences. So the filling up of fluid in the abdominal cavity is taking fluid out of the intravascular space and third spacing it in the peritoneal cavity. That can lead to low blood pressure and hypovolemic shock. And then the varices, particularly the varices in the esophagus around the stomach, those can rupture and lead to very significant intraluminal GI bleeding. And I'm sure a number of you who work in surgery and emergency medicine have seen individuals with known alcoholic liver disease present with vomiting up of blood, and very often you find out that those individuals have had hemorrhage of these dilated esophageal varices. Again, two major consequences of portal hypertension, each of which on its own can lead to loss of blood volume and hypovolemic shock. Here we see a couple examples of individuals with marked ascites, and we talked about, again, that lack of being able to move blood through the sinusoids in a scarred down fibrotic liver leads to portal hypertension. Portal hypertension backing up of blood back into the GI tract. Increased permeability of those blood vessels results in the leaking of fluid into the abdominal cavity. The other thing that happens is as the liver fails, the lack of building albumin in serum proteins will also lead to a lack of oncotic pressure, and that lack of oncotic pressure will result in the individual having an inability to get this fluid back into the vascular space, very similar to something that we saw with individuals who develop low albumin levels due to renal pathologies such as nephrotic syndrome. So then, in addition to those vascular consequences of portal hypertension, you're going to see metabolic consequences. So again, go back and look at that one slide showing you the different metabolic functions of the liver. You see that there are scores and scores of metabolic processes which can be adversely affected. Here are the big ones. Impaired glucose homeostasis can lead to hypoglycemia. Impaired bilirubin metabolism can lead to jaundice. Now, jaundice in and of itself is not going to harm you, but it's a nice marker to look at to see somebody who's got icteric sclera in skin and then work that up in terms of finding liver disease. Hepatic failure can lead to hyperammonemia, the inability to clear the nitrogen from the metabolized amino acids. That nitrogen is usually cleared through the kidney as ammonia and urea, but if you can't process that nitrogen into urea in the liver, then that nitrogen accumulates as ammonia, and that ammonia can definitely be toxic to the central nervous system. And then something that can exacerbate bleeding in a person with end-stage hepatic disease is their inability to synthesize those coagulation factors. So take the metabolic consequences and the blood volume consequences, and you can see that there are some very significant clinical pathologies that we can see in an individual with end-stage liver disease, both the two complications of portal hypertension and the metabolic complications which are listed on this slide. And then finally, this is really important, because the liver is so intimately involved in the metabolism and excretion of drugs, we know that drug selection, drug dosing, and drug kinetics can be markedly altered in an individual who has liver cirrhosis from any reason, but particularly alcoholic cirrhosis. So we talked a little bit about Hep A, B, and C. We spoke about alcohol in a little bit more detail, but understand there are numbers of different conditions that can lead to liver damage. Other infectious organisms. We didn't really talk a lot about malignancies of the liver, but the most common primary malignancy of the liver is adenocarcinoma. But we also mentioned this in other units, that there is a fair amount of metastatic cancer to the liver, particularly colon cancer and breast cancer. We talked a bit about alcohol, but understand that there are literally thousands of drugs and chemicals that can be responsible for for acute liver disease and end-stage liver disease. So always ask for a person you're working up with new liver disease or new onset liver disease, always ask about drinking, illicit drug use, what's the person's occupation and hobbies, as they may be being exposed to some type of chemical that they're not aware can lead to hepatotoxicity. I put that number there in red. That's the Wisconsin Poison Center. That center is open 24 hours a day, where you have the ability to speak with on-call medical toxicologists regarding patients that you have. particularly those patients who have liver disease and are trying to figure out what may be the cause of that or how that might be managed more effectively, particularly in something like a Tylenol overdose. I love the Wisconsin Poison Center. That was my place for a number of years. I was medical director of that program for about 16 years. And when I went full-time to teach at Concordia, then I still work in the emergency department over at Children's Hospital. The Wisconsin Poison Center is actually housed in Children's Hospital. And I assure you, even though that I'm not working with them anymore, they are in outstanding hands and have some awesome toxicologists there that you can speak with. So put that number in your brains and in your data banks, and don't be afraid to use that. And again, just consider on the slide scores and scores of other things that can damage the liver. We only touched on a brief amount of that stuff. Again, we've got a fairly limited amount of time in this class, so I think we just kind of did like a reasonably good overview of acute infectious hepatitis to end-stage liver disease using alcoholic cirrhosis as the example. So let's do a really quick thing here and wrap this up in a couple of slides and just really briefly talk about GI bleeding and working up GI bleeding. So number one, is it blood? And if it's blood, is it really coming from the GI tract? So that's just going to be part of your physical exam and using, Hemoccult to determine that, in fact, that is heme positive. Remember, people with bleeding disorders can have GI bleeding just due to the bleeding disorder. Types of GI bleeding include hematemesis, vomiting of blood. That can either be bright red or coffee ground. People can have hematochezia, which is blood in the stool. That can either look like melena, kind of like black purple, or bright red blood streaking. Upper and lower GI sources can be the source of GI tract bleeding, so anywhere from the nose, mouth, esophagus, stomach, proximal duodenum as the upper source, distal small intestine, colon, rectal, and anus as the lower sources. Always assess if this is life-threatening by symptoms, hemodynamic stability, the H&H. Is a patient bleeding due to some type of trauma, be it blunt or penetrating, right? That's often going to require a surgeon right away. Think of forced entry, either into the oral pharynx or in the anus as well. That can be a cause of GI tract bleeding. That might be something that the patient may not want to disclose to you. Is the individual anemic? If so, are they symptomatic or asymptomatic? Do they have cancer risk factors? Do they have IBD risk factors? Can you find some easily identifiable lesion, such as hemorrhoids? Remember, always assess the hemodynamics. Orthostatic blood pressures are extremely important in picking up individuals who have early symptoms due to anemia. In your history, ask about pain, vomiting, stooling, fever, diarrhea, constipation, and weight loss. How frequently are they seeing blood, and how much blood are they seeing? Does it seem to be stable, or is it increasing? Do they have other bleeding sites? Do they have a bleeding disorder? Are they on anticoagulant medications? Have they experienced recent trauma? Do they have risk factors for cancer? On your exam, look for obvious sites of bleeding, both at the north and the south pole of the GI tract, so nasal and oral pharynx from above, anal and rectal from below. Do you see signs of non-GI tract bleeding? Might the blood be coming from the vagina and its genital urinary in a female? Detailed abdominal exam. We talked a little bit about assessing an abdominal exam, a surgical abdomen versus the more benign non-surgical abdomen. And then guaiac the vomit, guaiac the stool. That might be helpful in determining whether that reddish brown color that you're looking at is in fact blood. And then imaging studies such as endoscopy, particularly the upper endoscopy and the colonoscopy, can be invaluable at looking at both ends of the GI tract so that you can localize this as either being an upper or a lower GI tract bleed. And then always remember that active bleeding plus hemodynamic instability means get a surgeon, right? If you've got somebody who's actively bleeding and showing you hemodynamic instability, get a surgeon involved. So let's do this. Let's try a couple of these, or actually I want you to look at all of these. What I want you to do is look at all of these little vignettes and think to yourself first, does this sound like a stable patient or somebody who might crash on me really quickly due to severe GI bleeding? Based on the vignette, do you think that this is most likely an upper or lower GI tract bleed? What do you think is the most likely etiology? So I'm going to put a couple of these on exam 4. And I'll put something like a quick vignette on here, and I want you to think about, is this happening quickly? Is this patient stable? Do they have the potential to become hemodynamically unstable really quickly? Where do you think this is coming from? Upper or lower GI tract, and what do you think is the most likely etiology? So go through these. I think you could have a lot of discussion on each one of these in terms of what do you think is going on, but try to keep it simple. Again, just think, patient stable, yes or no? Do you think it's upper or lower GI tract bleeding? And then based on it being upper or lower, what do you think is the most likely etiology? And again, I'll put a couple of these on exam 4. And with that, we have completed the final narrated PowerPoint. You guys are probably so sick of listening to me. So congratulations, we're done with this. Now be sure that you look at your due dates for the discussion board, the quizzes, and that last exam. Remember, I have bonus quizzes which are up for you if you wish to complete those, and I will add those bonus points to your cumulative. Please, please, please complete a course evaluation. That will be very helpful for me in the School of Nursing in revising this course for future individuals. And I know this was online and we never really met face-to-face, but if you're ever on the CUW campus, don't hesitate to look me up. My office is actually on the 3rd floor of the School of Pharmacy. So look me up and come in and say hello, particularly as if you're on campus for a clinical or getting close to your graduation, whatever. I'd appreciate getting to meet some of you guys. So again, thank you for taking the course. I hope you found it useful. Au revoir.